I hope everyone can find their seats so we can begin. I think it's always good to start the day with a bit of an exercise, isn't it? Don't worry, I'm not going to make you stand up and do any morning exercise. You already did that when you climbed up on the 4th floor. So I hope that all woke us up. My name is Johannes Tralla. I'm a journalist and I'm 40 years old. Now, according to Eurostat, the average Estonian man can expect to live about 54 healthy years. So that means my wife has about 14 years left before she needs to start checking if I've taken the right medicine. Now, in Finland, men enjoy about 61 healthy years, and in Sweden, it's close to 63. Now, that's nearly a decade more of good health to work and to live fully. And that makes me wonder, does it really have to be that way? How can societies so similar in climate and culture have such different outcomes when it comes to health? And quite frankly, it doesn't really seem fair. Estonian women, I think, deserve better husbands. Now, of course, staying healthy is ultimately a personal responsibility, but I guess health also depends on the choices we make together and the priorities we set as a state. Estonia is often praised for doing more with less. And considering our limited resources, I think it's fair to say that our healthcare system is quite efficient, certainly quite digital, and one could even argue well organized. But being efficient can also be a trap if it means we care more about saving money than improving results. In Estonia, we spend about 7% of GDP on health, while the EU average is 10%. And that means we also invest far less in prevention, in early detection, and in innovation. These are all things that actually keep people healthy and productive. Now, when we look at what experts say, that every euro invested in healthcare can also bring several euros back to the economy. So, quite frankly, it's not just about my wife and my life, it's also about the economy. But somehow that logic still doesn't apply when we look at the political choices we make and when we look at our budget. So today, we're going to ask, how can Estonia start seeing health not only as a cost, but also as an investment, one that makes our people, our economy, and our countries strong? Ladies and gentlemen, after the welcoming words, we'll hear 3 keynote speeches that frame today's main theme. Then our first panel will bring those ideas together, moving from research and evidence to real policy action. How would that look like? This is one of the questions that I'm definitely going to ask. Now, we're going to have a short coffee break, and after that, we'll look at the future. How can we really keep healthcare in Estonia sustainable and effective for the next decade? And how can new data tools help us make smarter choices? And finally, we're going to have our second panel, where we'll ask, how can we move from being efficient to making truly an impact, saving lives, strengthening our economy, and doing all of that, hopefully, at the same time. Dear friends, I'd really love to hear from you. Your opinion certainly helps to steer this conversation. And there are, well, at least 2 ways to make your opinion and questions heard. One is our good old digital platform, Slido. You already see the QR code. I see hands and smartphones up, scanning it. That's exactly the right way to go if you prefer Slido to post your questions. Now, those of you who prefer the good old way, we also have a microphone, so just raise your hand and I'll hand you the floor. I would like to also thank our sponsors for their generous support: Novartis, Amgen, AstraZeneca, Roche, MSD, and Medtronic. This event would probably not happen if it weren't for your good support. And now, ladies and gentlemen, to officially open today's forum, please welcome Hanno Bützep, Vice President of the Board at AmCham Estonia.
Thank you, Johannes. So, dear AmCham members, dear guests, dear speakers and panelists, and dear minister, a very warm welcome to this year's Annual AmCham Healthcare Forum, which is, by the way, in fact, taking place already for the 9th consecutive year. So next year we'll be already celebrating our 10th anniversary. And for the 4th year in a row, we have international speakers, and we have the Estonian Minister of Health attending, and a huge thank you for that. It means a lot to us. So we may say that we are establishing and securing more and more our role as a leading annual healthcare policy event in Estonia. So, but what brought us to this year's event actually started already a couple of years ago, when we became aware that the healthcare budget, close to 200 million deficit, is a reality and not just a forecast anymore. So we, together with Sorainen law firm and AstraZeneca, launched an online ideation platform with an aim to gather new and bold ideas on how to make the Estonian healthcare system better, more resilient and sustainable, and from where to find additional money to healthcare from. So we managed to attract more than 6,000 unique visitors. We raised more than 40 ideas, and then we shortlisted, combined those ideas, and discussed during our last year's World Cafe format style event. And all of that led us to publishing an AmCham policy paper on healthcare. And the overarching key messages of the paper is that healthcare is not a cost. Healthcare is an investment, and it's directly linked to economy. And throughout 2025, we have been introducing the policy paper to key stakeholders and decision makers within healthcare. So we visited the majority of the political parties at the parliament. We visited the Ministry of Social Affairs, the Ministry of Economy, of course also the Estonian Health Insurance Fund, and etc. But how do we move forward from here? We know that our disease burden is high, much higher than in some similar countries. And this, the Estonian people are losing roughly 1/3 of their lives to diseases or premature death. And when we translate that third to money, then we know that Estonia is losing at least 1 billion euros in yearly lost tax income. So do we need additional money to healthcare? I would say that yes, definitely. But I also believe that we all agree that before we start investing additional money, we should understand and be confident that the money that we currently have is spent in the best possible way. As Johannes also pointed out that, and it's already widely known, that in healthcare, whilst you invest €1, you get at least €2 in return. But does it apply to absolutely everything within healthcare? Probably not. Probably there are still areas in which we are still even losing money. Probably there are areas where we do not get that peak return. And probably there are also many areas in which where we will get back much more than the €2. Hence, we need to understand where our money is spent and which impact it has. Estonia is a data-rich country. And now, whilst we are moving from the PDF format style data to usable data, I think it's more important than ever that we need knowledge, competencies, and smart tools in order to use that data to make clever, smart, and informed decisions. One of AmCham Estonia core values is to advocate for effective private-public partnerships. And we in the healthcare committee like to walk that talk. And we see our role as a body that helps to bring the international expertise, know-how, and best practices to Estonia, so that we could inspire the thinking and commonly find answers to the burning questions on how to move or make the Estonian healthcare system better, more resilient, sustainable, and at the same time, how to strengthen our economy. So, what would be a better place for those discussions than the leading Estonian business school? And with that, I'm happy to invite on stage my alma mater Chancellor, Mr. Mart Habakuk. And thank you.
Good morning, dear Minister, AmCham members, guests. EBS, as was mentioned, is the anomaly of Estonian education system. It's the only private university. But I wanted to take a quick morning brain exercise to think that the healthcare system and education systems in Estonia, they have lots of similarities. They both provide public good and private good. They are overwhelmingly provided for free. And what if the higher education system is managed similarly as the health system in Estonia? Now, first of all, the hospitals will be financed not so much about what services they provide, how many patients they treat, what treatments they provide. And actually, nobody doesn't know even exactly that. The hospitals will have quite intense marketing departments, multi-million-dollar or euro budgets to compete for patients in the country. And also the hospitals will have their basketball teams playing in Latvian and Estonian league. These were a couple of things that come up with. But I think the most important thing is that both systems, they are operating well. And this is thanks to the people and the talent that works in those systems. And these are people not working there because of their bonuses or fame, but working there because they care. And I wish you all a good forum today to lots of new ideas, but more importantly, and this is the EBS way, that these ideas will become an actions, and in actions will become an impact. Thank you.
Thank you very much. Now, to set the tone for today's forum, we'll hear from someone who's really at the heart of shaping Estonian health policy. Please welcome Karmen Joller, the Minister of Social Affairs of Estonia.
Thank you. Thank you all guests, the hosts, and I'm very honored to be here. Well, actually, Hanno Pütsep already told most of what I wanted to say. I'm very thankful to you because now I can focus on more interesting topics, but it's also, of course, very important and interesting. As we all know that most of developed countries face similar problems. Healthcare costs are rising, populations are aging, at the same time we are in very large need of healthcare workers. In Estonia, if you compare it to Finland, well, our doctors and nurses went to Finland, so maybe that's what helped to improve the Finnish population. But also, we had a very good report. It was published some days ago, very recently, about Estonian costs of healthcare and how the costs are moving around in Estonia and how much we actually lack. Well, we lack just 1 billion, and that's exactly what you mentioned. We actually could gain from smarter decisions. There was also a little bit funny recommendation. It was very smart, actually, but it sounded a little bit funny. It showed that if we would raise retirement age by 5 years, we would gain again the same billion euros we are missing. So very simple, just let's raise the retirement age so that people would work up to 70 years of age, and then no problem, we would have all the money we need. But the healthy years is the problem. So the men should work maybe 15 more years unhealthy. Women a little bit less. And are they productive enough? Or maybe they actually don't feel very well. Maybe they won't like to work on full time. Everything in healthcare and also welfare is about economics and vice versa. Healthcare and welfare of people is actually the basis of economics in all countries. I am a doctor by profession. And when I talk to my young patients and I ask them, well, how do you live and what are your habits? I ask about their thoughts about tobacco and e-cigarettes, alcohol, cannabis, how they share their time between rest and maybe smartphones, or how do they relate to school or parents, etc. And when we speak about a lifespan, they usually say, I don't want to live more than 60 years. Because 60 years seems really, really old to young people. At the same time, our lifespan is increasing. I have also old patients. Well, I don't have any more. I'm a minister now, but I had. For example, I had 97 years old German. He died when he was 100 years old. And I remember a day when I was finishing my day and German gave me a call on my mobile phone. Well, I shared my phone with him once. And he said that, I have a pain in my knee and I would like to come to see you. I will come at once. He lived nearby, maybe 500 meters or 400 meters from my office, but it was February and it was slippery. It was extremely slippery. And I could not imagine that he would walk and fall down. I had all thoughts that would happen to him. I said, no, please don't come. I will come to you. It's very close. I'm just finishing my day. I will come. But he had problems with hearing. So I understood that he would come anyway. I gave a call to the elderly home he lived and said, please don't let him out. I will come in a very short while. And when I put down the phone, I heard tuk, tuk, tuk in the corridor with his walking stick, He was already there. Well, who would like to be like him when he or she would be 97? Everyone. That you will give a call. Okay, you don't hear very well, but everything else is very normal. Also, I had a walk, it was a month ago. I had a walk in Tallinn, and I met she was 86-year-old lady who was roller skiing. And I said that, wow, you're roller skiing and you look elderly. How old are you? I'm 86, but I'm not very experienced in roller skiing. I started it only when I was 79. So we all would like to be like these people. And these people actually they come from the era where there was no modern, nowadays, medicine. Of course, past maybe 20 years, they probably took some medicines that would prolong their lifespan and make better their everyday life. But, and also maybe they already had some joint prostheses or some other. I remember German had a cancer operation when he was 92. But if we think how medicine is advancing, what is the pace? It's like rally. It's very fast. And nowadays, we can diagnose very early the diseases, for example, also on fetus. And if there is a very, very serious disease, the family can decide that they need abortion. So, and even if the child will be born, we can already prepare for treatment and sometimes for very early interventions to make life easier for this child and this family. We also have, as I already mentioned, all the prostheses. So when I talk to these young people who would like to live only 60 years old, I usually tell them that, I'm sorry, but if you really drop dead at 60, maybe sometimes at 50, ambulance will come and they will revive you. It's not your choice anymore, not so much. And actually they can replace your lungs, your heart, your kidneys, your liver, your joints, even some parts of your eyes. You can have prostheses for hearing, for many, many things. And it's up to you to decide the point of the time when this will be happen, if it will be at 60 or maybe at 90. Thus, the lifestyle is the most important. And then maybe they start thinking, maybe not, but as a minister, I think that it's very important to prevent diseases, and equally important nowadays also to treat the diseases and give the right time for diagnosis and treatment. So the core question is how we can make the things where the money we spend on healthcare and investment, as we are discussing here. And if we consider private money also besides public money, then we have to decide whether or who is more important, the person who is working and should go very fast back to work, or the person who is aging and might need a lot of help from the same person who needs to work. So these are the core questions. I hope we will find answers quickly, and this is how we should also set the rules for policies. Thank you.
Thank you, Minister, for sharing a personal and professional view also next to your political vision. Ladies and gentlemen, I don't see anyone posting any questions on Slido. Let me see if that has changed in the past 3 seconds. No. Maybe the minister was super clear on her vision, so you don't have any questions, but just in case, if you have a question, you can raise your hand, let me know. The minister is here. She'll be here for the panel, so it's fine if you don't want to ask now. Let's move on, because I don't see a wave of arms in the hall. So now let's take an even broader look. Our next speaker really brings a global perspective from the McKinsey Health Institute. Now, their recent study shows that, that shows actually something quite remarkable, at least for me as a journalist. If Estonia gave more people access to simple, proven health measures like prevention, early detection, and smarter use of resources, people like me could actually live 6 more healthy years. I'd like to be like German and walk to my doctor's office when I'm 97 years old. But 6 more healthy years even actually feels better. And every euro invested in health could actually bring back 5 euros to the economy. Now, to tell us more how that actually works, please welcome Alex Bouvet from the McKinsey Health Institute.
Hi everyone, thank you very much for having me. It's my first time in Estonia, so I'm also enjoying the opportunity to discover your country, so thank you very much again for welcoming me here. So we'll speak about prioritizing health, and to give you a quick introduction, so I'm director of the McKinsey Health Institute, which is an independent institute focused on researching topics like longevity, women's health, brain health, children's health, and how they can help accelerate the economies of countries by investing in those, at times, underinvested topics. So we'll go through different topics in terms of how did the burden of disease evolve in Estonia over the last 25 years and what it means in the current situation. So it's going to be a little bit data heavy at the beginning, but hopefully that's not going to be too data heavy. And then we'll go through what can this look like for the next 25 years and what sort of interventions can yield what in terms of return for the economy. We're going to speak about health as an investment, that's for sure, but also health as a cost to manage. So if I look at hang on, this one is here. Oh, there we go. So if we start with something like from the very beginning, just talking life expectancy, over the last 70 years, it has grown like quite significantly. And you'll see the most recent research we've been working, I'll send you the links after that, on prioritizing health. Here I'm going to look at the prioritizing health part of the research. So there's been like meaningful progress on life expectancy pretty much everywhere, and especially in Estonia over the last 25 years. But what is important is to have a look at how do you look at life expectancy, but also healthy life expectancy. We heard quite a bit about that already earlier today, but there are some specific, I think, facts to look into that. So if you look, for example, over the last 25 years, there's been 8.4 years added in terms of life expectancy in Estonia. 6.8 are in good health and 1.5 are in poor health. What this practically means is that in 2025, like for a life expectancy of 79, the healthy life expectancy across men and women is 69. That means it moved from 8 to 10 years of poor health per person. And those 2 years per person, they are bearing a meaningful impact in terms of what it means for the healthcare capacity. We heard about questions of shortage of healthcare workforce and so on. So that is like one part of evolution, to really think about life expectancy on one end, but healthy life expectancy as a meaningful trigger of what are the implications on the healthcare system. If you want to understand where the difference of healthy life expectancy comes from, there's two different parts of the problem. There's the years, of life lost due to premature death, and you have the years lived in poor health. And that's a very meaningful different picture for Estonia. Frankly, this is something you see quite globally as well. So there's been a lot of decrease in the years lost to premature health. We're talking a lot on the questions on CVDs. Well, this remains an important topic on cardiometabolic health for sure. Cardiovascular disease still accounts for a lot of premature deaths. Still, there's been a decrease on that, which ultimately fuels very directly the number on life expectancy. That being said, if you look at the years lived in poor health, they go up and they will continue to go up. That is the core source of why the burden, when we're saying the burden of disease goes up, it is not equally true on the premature deaths. It's actually less true on that matter and much more true on the number of lives lived in poor health. Now let's go into, I promise it's going to be like not too much data, but still I think it's quite important to look into, so what are the drivers? Where is it coming from? So if you look at that this way, what you can see on the right is that there's a very direct correlation, obviously, with age. Your population is aging in Estonia, and it's also a rise of non-communicable diseases. So you find in there mental disorder, neurological disorder, cancers, diabetes that are expected to go up over the next 25 years. I mean, I was noting the numbers before coming. This is, diabetes for 2050 is expected to go up 36%, cancer 15%. By the way, globally, those are the same trends that we're seeing. But if you put that in perspective of 2050, if you just look at the predictions in terms, and the models in terms of life expectancy, what this is expected to mean for Estonia, it's a life expectancy that keeps on going up a little bit across men and women, and we're talking about 83, and then healthy life expectancy, 2050 at 71. What that means is now 12 years of poor health per person. So across a span of 50 years, this is moving from 8 to 10 to 12. And this constant increase of the number of poor health years per person will yield meaningful implications on how the healthcare system functions in Estonia. What is quite important as well is when we're talking about the years of poor health, they're not just for elderlies. They're across the entire population. So if you think about it this way, and if you look at it that way, that's 63% of the years lost to poor health are within the working population. You could argue that even for a country with a smaller population base, it impacts even harder. So in that context, you're landing on really a fundamental problem, that is this increase of years in poor health per person are actually impacting everyone, including the working population, which directly ties to the ability to produce, to grow the GDP of the country, and ultimately there's a very direct link between health and the ability to grow the country. So on the right-hand side, there's a number that's a big number. To be perfectly clear, it accounts everything. So even things that can't be taken care of. It accounts for all the years due to premature death, all the years due to poor health. It accounts everything. And as you will see in the research, we don't think everything can be addressed. But still, to give an order of magnitude, we are talking about like 13 billion in 2050 lost due to all cause of that. So the reason why this is important to anchor on that number is not because it's a big number, but that's to give an order of magnitude of the size of what we're talking about. So now if I move on, what can we do about it? So the study we have been working on is looking at 300 interventions, and all of them are cost efficient. None of them are like extremely advanced. We are talking about the core, most simple, directly evidenced measures. What if we are applying that across the board globally? And here the numbers I'm going to show are the ones related to Estonia. 28%. What that means, and I will explain what's behind the 28%. It means by using the most cost-effective, well-evidenced measure in Estonia, there's a possibility at 2050 to decrease the disease burden by 28%. I would totally agree that 28% is not 100%, but keep in mind we're only looking at the 300 most cost-efficient, well-evidenced measure. So, and if you are the thing, and the reason above this 28% is important numbers because you factor, if you look at 2050, we're talking about 4,600 less early death per year, and we're talking about 53,000 healthy life years every year. If you bring that in perspective of 1.2 million people per country, that's very, very meaningful. So where does it go? As you can see here in dark blue, if you apply the most cost-effective, straightforward, evidenced interventions, this is by how much you can decrease the burden of disease on each of those conditions. So one could argue there's two ways to read that chart. You could say, oh, there's still a lot of gray. Yes, there's still a lot of gray. That means like this is not enough to just look at prevention measures, ability to manage chronic diseases. There's also more research to do, and I'm talking about pharmaceuticals' role here as well on some other diseases. There's more work to do. But still, starting from how much disease burden can be averted by using the most evidenced and straightforward interventions, this is the size of the prize on that one. So it doesn't solve everything, but it's a gigantic start to be able to benefit from the most straightforward actions that ultimately will yield a direct result. So what are those interventions? I mean, you have like three types of categories. Top left, you would find the typical things you would expect to see in public health. You're going to see things related to healthy food. You're going to see things related to tobacco controls, those types of things. So that's top left, that's 17%. I would encourage you to look at the bottom left, which is more like proactive care and what can be done at the level of the individual in terms of cardiovascular prevention, in terms of basically a rise towards cardiometabolic health type of prevention and activities. And then top right, as you can see, there's still a lot to do, which is more like better treatments in general once somebody is sick. So what are the implications? I mean, the implications are different ways. And here I'll go to two types of implications. Implications on individuals. Ultimately, health is, for all of us. So what does that mean for individuals? And then we'll look into the economy. So what it means for the individuals, and we heard a bit of that discussions a bit earlier today, is like if you look on the on the x-axis the age and on the y-axis the health. So some would say lifespan versus health span. So on the left, on the horizontal axis, this is the life expectancy, and on the vertical axis, this is the ability of someone to function. Health span. So the reason why those questions are really, really meaningful is because beyond the impact we're going to see on the economy of using those applying them at scale, it gives us an opportunity to, we say, lift, square, extend. So we at times forget that this is how it's supposed to be. As a species, we're not built in the first place to be sick for the last 15 years. As a species, we're built normally to live like pretty functionally, and normally it ends reasonably quickly. This is how it's supposed biologically to be. So at times we forget like that's fundamentally how we are built. So like going further and a bit back towards in that direction, indeed with those measures, as I was saying, life expectancy is expected to go 2050 in Estonia at 83. You apply all of that, it has a shot at going more the 86. And then we were talking about, and that's where the 6 years were coming from that you were referencing to before, this is moving from 71 to 77. So those numbers in and of themselves, they matter a lot. 6 years, we could all do a lot of things with 6 years. That's the difference between lifting grandkids or not. Those are the difference between like skiing or roller, you were saying snow skiing or roller skiing, just before at a certain age, or the ability of your patients at 90 to be able to go visit you with autonomy. It changes an entire life, leave alone running, just walking. And the other reason why it matters a ton is if you factor in just the difference, we're talking 9. This is reversing the widening gap between life expectancy and the number of those years in good health. We're talking 9. This was 8 in 2000, 10 in 2025 where we are today. If doing nothing, that's going to be 12 in 2050. And 12 years of poor health per person is going to create meaningful strain on the health system, leave alone healthcare capacity and so on. So investing in those measures and investing in that part of health has also the possibility to shrink that gap again and to go back towards 9. Implications on the economy. Because investing in health is not just the right thing to do, that's also the smart thing to do. And if you look at that, there are, and I'm not going to go into all the details of all of them, but if you start to measure how do you go after measuring the impact of GDP on those measures, you're typically tipping about 2 big categories. On the left-hand side is more people participating to the economy. And on the right-hand side, this is the individual productivity of each person. So on the left-hand side, obviously, if you have fewer healthy deaths, you have more people. If you have fewer health conditions, same thing, you are reducing the disability and you have more engagement of your population and less lost days per person. And on the bottom left, which is something which is at times forgotten, also informal caregivers. By the way, many of whom are women. So there's also questions of gender equality on that as well. So thinking about in fact, one person that's sick or not fully functioning is usually consuming not 1, but 2 people. And on the right-hand side, we're talking about the increased productivity. Obviously, number 5, critical. How early do we start? If you start with children, then it compounds. It's like in financial equations, it compounds. Similarly, if you have better health in an early age and the ability to pursue all of your studies and ultimately your ability to take more responsibility in society, it compounds. So that's item number 5. And item number 6 is linked to the other one, which is on the caregivers part. Potential for GDP, 3 billion euros 2050. So it's interesting, we're talking about 1 billion. Here's a way to find 3. 3 in 2050, that's 5% of your economy. The reason why is because the cost measure, the interventions I was talking about before, those interventions, again, they are more like the straightforward ones. Those straightforward ones that are very anchored, as I was showing, towards prevention, towards taking things as early as possible, they are applying to everyone. Obviously, they are having a meaningful implications on elderlies. That totally agreed with that. But it also has high impact on the working population. And the working population is the one that brings you GDP. So yes, you're not expecting that much uplift on GDP for your people that are at the age of 80 or even 70. But for all the people before, you're expecting a GDP uplift. This is where your GDP uplift can come from and how it is distributed across the population. 5 euros. I don't disagree with the 1 euro gives 2. But there are some specific measures that have a better return. So if you invest, and that's where we're talking about at times opposing a bit cost of healthcare and investment in healthcare. I think the rule of investment is to exactly know what you're investing into, and to invest precisely on specific topic and to expect a specific return. So I think across the board, investing is always a good move for health, and you might have a return of 1 to 2. But if you prioritize the investments on specific measures, and for example, the set of 300 I was talking about, you can expect, and you should expect actually a higher return, which is where you're getting a 1 to 5 type of ratio. So a couple ideas on how to go at it. Because that's all great on theory. Practically, what do we do? And that's where there are just a handful of ideas, and be happy to discuss about it. And I know there's a panel after as well, so we might go through some of that. The first one is to reframe the narrative. I was impressed, and I was mentioning that to the minister as well. I was impressed that there is such a conversation and emphasis being put on investing in health. It's not common. I would argue that I'm fortunate enough to travel in multiple countries and see multiple healthcare systems. I am impressed by the fact that this is front and center, not just of think tank conversation, but front and center to what we just heard from the minister. And I think this is a real advantage, because there are many countries where that discussion does not even exist. So the fact that it does exist here, I think is a wonderful start. So I will really continue in that direction. Similarly, on the second one, I would not discard entirely the question of cost. Ultimately, healthcare and healthcare system is a cost to manage very well. And the reason it's important to manage it very well is because that's also the way to create space for investment. Ultimately, investment is not the enemy of cost, and cost is not to be necessarily opposed to the investment. There's on one end managing well the cost of the operations, And on the other end, having an operating model for investing smartly on the things with the highest return and to expect a return from them, which are two distinct activities to have in parallel. Then coalitions on the third one, maybe two different ideas here. I think usually budgets are a bit too segregated towards healthcare is a budget on one end, social care is a budget on another end, investment in environmental health is something else. Like ultimately, I think there's a question of bringing those types of investments more together and pooling those investments. There is certainly one idea. But the second one, and we heard a little bit about it earlier today, public-private partnership can be another types of coalitions and things to be able to bring together. And finally, on the right-hand side, I think this is where, like, was mentioning as well to some of those discussions, like, I'm hearing a lot about Estonia on data and digital. As in, like, what are the main examples we can cite in the world when it relates to data and digital in healthcare? The name Estonia is coming up a lot. So I think this is first something that you should take, an immense pride of. I think this is really resonating and this is well known. Now, I think the question is, what result is that going to give? How is that going to use for scale? How is that becoming the distinctive advantage for accelerating investments and making those investments deliver? So maybe couple ideas here. I think there is one idea in terms of thinking about data in a pretty broad sense. Healthcare data is just one thing, but ultimately the highest predictor of health are also social determinants of health. Income is one of the first determinants of health. So like understanding and getting the data really like beyond, and where you're thinking about those questions of socioeconomic background, education, income, environment, and starting to look at the data in a pretty broad sense in order to be able to use it together would be certainly a distinctive advantage to be able to invest in the right measures and roll them at scale. And then I would also like cite maybe two examples that I'm seeing in different countries picking up steam quite fast now. One, and it has different names. Some call it population health intelligence. Some call it like precision prevention. What this practically means is to be able to use the type of data I was talking about before in order to be able to detect which people in the population are at risk and then having an operating model to be able to engage them proactively. Some countries are launching things next to their healthcare system, which is really focused on prevention. Said differently, they are starting from the idea that the current healthcare system is about taking care of sick people, and they will still going to be sick people. And that is the objective function of the system as it's used today. So why not embracing that idea and having next to it a prevention system with people even from a different career path? Like, what does it mean to be a good preventer? What do you need to know? Do you need to be a doctor? Maybe not. Maybe you need to have like a heavy background in cardiometabolic health, like good developed psychology, ability to engage people in behavior change. What does that mean? Who are those people? What is this profession? So there are those types of questions which I think could be an idea. I'm not saying they are the answer. I'm just saying this is an idea that I'm seeing in different countries popping up and that I think could be of interest in the context of Estonia. And I'll finish on like, another idea, which is I think next frontier, where I'm seeing that in many places, and again, thanks to the advantage in data and digital you might have a better shot even than others, which is what's the role of the patient. Empowering the patient is really starting to become like more and more the topic of the day. How do you, and at times the people go at it with different ways. They either go at it with the idea of, hey, if we're able in many industries to empower the patients towards self-service for their bills, for their invoices, how far can we take the idea of self-care? Same thing, I'm not saying that's the only idea. I'm just saying this is something I'm hearing more and more about. So I would encourage that maybe to be a conversation that might be an interesting unlock in that journey. So what's the role of the patient? How much data do we give to the patient? Do we give even the big data? And by big data, do we tell the patient what is their life expectancy? Because we can model it. Do we tell the patient what is their healthy life expectancy? Because we actually can model it. Is that too much information? Is that empowering information? I don't know. Like, jury's still out on that. But if you have the data and the digital capability, those are questions you can have and questions on which you might find a better answer than everybody else. So that was everything for today. I hope that was helpful and provide a bit of context. Again, thank you very much for having me. And I'm looking forward to the panel and questions.
Thank you, Alex. We actually have a few questions now, and perhaps to save time for the panel, I'll go ahead and ask a few of them. So some of the 300 interventions that you showed were borderline cost effective. But what were the most cost effective ones? And were there any cost saving ones that you could point out?
Yeah, I mean, and after that, I appreciate there are questions about industries and all of that. But if you look at, I mean, there's even some papers that exist, and the type of words you find in those papers are the words like best buys. You have the WHO best buys as an example. They are the tobacco campaigns. They have a return of 35 to 1. So you could argue, yes, but it means X, Y, Z. I do not disagree with that. But still, there are some interventions that have very, very high return, like those ones. I would put second the interventions on cardiometabolic health at individual level. Same thing, they also yield a high return. They come with questions of how do you engage in behavior change, obviously, so the operating model to make it happen, but that's much more where that is. So healthy food also comes very high on the list. So most of them are great common sense, which are anchored on tobacco, alcohol consumption, healthy food, cardiometabolic health at scale. Those are more in that area that the main interventions are.
Mm-hmm. Is there research on the maturity readiness levels of national healthcare systems on adopting innovative technologies? Any good examples?
I love that question because the answer is a resounding no. It's a resounding no, and this is one of the questions we have as we speak, and we're reviewing a plan to go at it beginning of December for the annual planning of the McKinsey Health Institute. There's a lot of healthcare system. By the way, none of them are competing against themselves, but they all crave for learning from each other. Because in fact, there's many innovations that are very relevant in different countries that would transpose very well to the next. What is not existing is the maturity level or something commonly accepted. And transparently, we're working on something called the Health System Performance Index, which is a maturity scale for health systems, so that they're able to both see how they're performing on different paths, but also finding a good forum to structurally exchange best ideas and transplant them from country A to country B.
And we'll take one last question. We've extended life expectancy, but that brings more diseases like cancer. Now, how should we balance the economy and focus more on secondary prevention? Any ideas on that?
So cancer is expected to rise, as I was saying, about 15% increase of burden. You could put the same questions toward diabetes, which is even greater than this one. I don't think this is either or, and I would look into both optimizing the cost of the operations, as in productivity, ensuring the maximum is used in order to make the machinery of treating sick patients work really well, in addition to which, investing in the specific interventions that are the highest possible impact for the country. The thing is that the activity of operating is different than the activity of investing. So I think managing well the cost of the system is just, I would say, good hygiene, productivity management of the operations, which are a necessity to be able to invest wisely on the different prevention programs in particular.
Thank you, Alex. We'll continue this discussion in the panel. But to keep going with the program and to hear from our next speaker, she will actually continue on the same theme, looking at health not as a cost, but as a powerful driver for economic growth. Dr. Carla Hernandez from the WIFOR Institute has spent years measuring the real economic value of health, how every euro invested in healthcare can return several euros through higher productivity and lower social cost. And she'll show how this idea is already shaping policy in other countries and what Estonia could learn from that.
Happy to be here today, and we are very happy to still bring in these ideas around, and I feel really fulfilled to see that these forums are bringing the question of health as an investment and going out a little bit of the idea of health at a cost. The presentation that I want to bring today is a little bit to explore why we're still seeing this health as a cost. And then I'm going to talk about some certain measures that we could put in place to understand the level in which health can grow our economies and how we can see this in a holistic way, and some points for Estonia as well. Then let's start to why. Why is health still seen as a cost factor? Well, first, I'm sure if I ask you, especially in this forum, what do you think about the sentence health is related to growth? You will be really agree with that, no? And the literature is also agree with that. And most of the people will be also agree with that. But this is not reflected in policy decision. And this is the question mark, why we are not considering that. Then one point here is actually also excess bias in individuals that are reflected in policy decision. For example, there's present bias, no? Then we have that short-term gains are valued higher than long-term benefits. And there is what health lost their point. This is why we have a lot of problems funding some prevention programs in countries, because we need to demonstrate there is a short-term value of those interventions. Then we have this optimist bias as well. We underestimate the crisis, the risk of crisis, the risk of health risk as well. And then we are not really well prepared for those. And we have already the example that everyone knows with COVID. And we know as well that if another crisis like that comes, we're still not that prepared either now. The other point is this loss of aversion. No? We have that in policy, the politicians live in the cycle of in the political cycle, no? Then they need to show the voters that they have making changes that have been positive for the country. Then to invest in something with the benefits are seen in social long term is considered sometimes a little bit risky. Then that put also the investment in health a little bit down into the list. The other point is that if you hear in the television the health expenditures have growth, that always have this negative concept. Health is looking as a consumption and not an investment. If you think about education, increasing in education investment, increasing in transportation investment, the feeling is order. Not that this negative concept about investment in health, even if we are not looking at where the investment is going. Then that can be the transportation. There is many examples in Europe in which they have been putting money in transportation that didn't bring any benefits for the countries. And then the point is how we can face those ideas, how we can change this set of mind and give the policymaker the tools that they need to make decisions. Then the first point that we need to go is understand where is the water that we put in the health investment growing the economy, where in which points we can measure that. Then we have been working, or we have identified 3 main points. The one that is normally measured, this traditional approach that is investing in cost effectiveness, new interventions in which we have that there will be increased efficiency of the healthcare sector and it will be increasing in health outcomes. But there is other 2 points that we have been ignoring. And the first one is what we call the health economic footprint. And this is something that you don't hear that much. And this is the idea that health is a very well-connected sector with the rest of the economy. Then when you invest in health, you are actually producing a spillover effect that go to many other economy and grow the economy in general without anything to do with health outcomes. The other part is this social impact. And when we talk about the social impact, we think about productivity. And I'm going to talk about that more in detail in a moment. Then let's start with the social impact of the health investment. What we are referring to. The idea with the social impact, where I want to start with this other concept, which is the socioeconomic burden of a disease. And here is the extent to which a disease are going to deteriorate the capacity of a person to use their capital. Everyone knows what is human capital, all the abilities that we bring to produce in the market. And when we have a disease that reduces that, we have a direct effect in the labor market, in the supply. Then why we need to understand the socioeconomic burden for the different diseases? That's the question. The first thing that is important for us to understand is that everyone matters. Every individual contribution to the economy matters. Then when one person cannot fully fulfill their capacities, every one of us is affected. Our well-being is affected. The other point is what I already say about the labor market. Then a socioeconomic burden means a decrease and a negative effect in the labor market that start for increasing problems that we already know, like skill gaps, for example. In Estonia, there is an important skill gaps in In the ICT sector, the technology sector, we have also that chronic diseases are now affecting more population in working ages. We have also the aging problem, the demographic changes, and we have also the point that labor market is a very important part in the politics decision of the government, but health never look like to be in the list of potential political decision to improve the labor market. And finally, inequalities. Socioeconomic burden is a factor that generates additional inequalities. People in the poorest levels that suffer for absenteeism or presenteeism are the first ones to see their income being decreasing, increasing the problem there, and also generating all this vulnerabilities, all this intergenerational impact. If you, as your family, can need to cover for a disease, then you will have less money for investing in education of the next generation and increasing this poverty cycle. The other point for us, very important to clarify, is that we consider that it's not only about paid work. Unpaid work is very important. And what I'm referring about unpaid work is everything that you don't do and need to be paid for someone else. Cooking, washing your clothes, cleaning your house. And why is unpaid work important for our economies? Well, I don't think here daycare is paid, but if you have 2 children, for example, and no one to take care for them, you need to stay at home. Normally, the woman stays at home, and the participation, the potential participation in the paid work decrease. We have, in some families, the grandma take care of that, then the person can go to work, the paid work will increase, then unpaid work is somehow facilitating paid work. If we don't have someone to cook for us, we cannot work either. No, then we need to recognize that unpaid work is also an essential stone in the productivity of the countries. And we ignore that, and most of the studies stop considering productivity losses at the age of 65, when people is retired. A person of 75 is still having a very important contribution to our economy, and we need to start also recognizing that. I brought here an example of one of our studies in which we measured socioeconomic burden for some diseases. We measured it actually for more diseases, but I just wanted to have a very clear example here. Then we have Portugal and Czech Republic, and what we did here is mortality is measured for 1 year. Then after 1 year, the person is replaced in the work position. Then you have here, the blue line is cardiovascular disease, the light blue is diabetes, and the red is migraine. We have Portugal and Czech Republic. You can see how the socioeconomic burden is increasing for diabetes in both countries along the period of the study. But interestingly, migraine in Portugal have a higher socioeconomic burden than in the case of the Czech Republic in terms of importance. And we have the cardiovascular disease for Portugal come very down if you compare it with the case of Czech Republic. Then the socioeconomic burden is not something that you can just put and say it's going to be the same for every country. You need to actually recognize what are the differences in your own country to kind of use that information also to establish some priorities. Okay, the next point is how we can then reduce the socioeconomic burden. And here we are proposing to compare this socioeconomic burden with in terms of different interventions. The most easy idea is, we have a scenario 1 in which we use the standard of care, the current treatment, and then we compare that with when a new intervention is applied. We do that first. The main stone is health. Then we need first to have a treatment that is safe, and have a certain level of efficacy. Then once you have established that, then we can see how that increase in health outcomes can be measured as an increase in productivity of the country. We need to establish a bridge that in some cases is not that easy to measure. We use a different set of methodologies, but just when we have done that, then you can transform that in terms of hours of paid and unpaid work that are lost in a country. And then you can give that a value, a monetary value. Differently that the normal cost, the traditional cost effectiveness model, what we do is we use what is called gross value added. I think maybe some of you are familiar with the definition, but the idea is what a sector is bringing to the economy after paying for all the inputs that they require. That we take that as a metric per person an hour, and it gives us a better idea of how much the economy lost when a person cannot go to work. And that is different than using wages, because wages is connected to the supply and demand. And it is it's not reflecting the productivity of the country, but it's reflecting the condition supply of demand of the labor market in those countries. Then we use this other metric to actually see how much an economy is losing. And here I brought the example of a study that we did with a group of countries for the application of inclisiran. Inclisiran is a drug that reduces the low-density lipoprotein cholesterol, which is linked to the risk of cardiovascular diseases. Then we compared the application of approval of that particular treatment in a series of countries. And again, the first thing that you can see is that for each one of those countries, the social impact effect of applying the same product is very different. No? And here having to do with epidemiological factors, it have to do with economic factors, have to do with also the split between unpaid work and paid work in the age groups. The second graph that you have here is for the case of Germany. We took from these countries the case of Germany, put it there, and you can see how unpaid work and paid work losses change depending on the age group. Don't worry. Depending on the age group. Then you can also argue that probably after 80 you will work, that you can ignore that, but at least until 79 you can see how unpaid work is a very important part of the productivity losses of that group. Okay, and now the second point, the health economic footprint. We have been working on the idea. When we think about health sector, we think about inpatient and outpatient, but actually the health sector is far bigger than that. We have many other parts, like pharmaceuticals, health insurance, etc. Then it's a very big part of the economy that bring a lot of GDP and a lot of well-being, and that is very connected to the rest of the economy. And that's what we wanted to put here clear in this health economic footprint analysis. That you have here these three circles. When you put money in the health sector, first you grow the health sector. You have more people contracted, you have more elements used, you need to buy that. Then you have a first increase in the direct, as what we call direct effect. And then this increase, you will buy in other sectors, inputs, and then we have a second kind of wave that we call indirect effect. And once you have direct and indirect effect, you have an increasing income of consumption that will be reflected in an induced effect. All of this grow the economy without any relation with health outcomes. What is that important? First, because what I mentioned in the first slide, we need some kind of measure for the short term. We need to bring health investments at something that will increase our economic in a very short term. And this is the first point here. We need to give policymakers the tools to decide to compare health sector with other investments in other cross sectors. And that allows us to do that in a very short time. I brought here an example of 4 countries of the Commonwealth. That is the expenditure in HPV vaccination. And you have the case, for example, of the UK, that they invested in 2022, 134 million here. And if we look at the first one, I don't think I have a point. The first one is the direct, the second one is the indirect, and the third one is the induced effect. If we look at that in the first year, just the first years of investment is almost twice the amount of money that have been paying for the program. And you can see the same in the other countries. You can, in the figure here, what is interesting to see is the difference in those 3 effects. And that depends on how connected the healthcare sector is with the rest of the economy. It's not the same, the health sector in India, in which we have a lot of production, that if you look at other sectors like Nigeria or in Malaysia. Okay, then almost, I hope I'm still having a little bit of time. Just tell me when I have talked too much. And then what we need is to consider these 2 points of view together to understand actually how the water of health investment is growing our economy. And these two words are joined together by the labor market dynamics, like you have in the middle. But I brought here an example of how we analyze these 2 words with the case of a cardiovascular disease intervention, a prevention program that we evaluate for Estonia. This prevention program, the idea was to divide the people between 3 levels of risk: low, middle, and high. For those in the low level, there was just recommendation of changing habits. For those in the high risk level, were also recommendation to take certain medicines. Then there was different in these 3 groups. And these people will be calling or will be getting the invitation, because here you have access to some data, access to some information for them that allows the doctors to divide them by categories. Then the first graphic here is the health economic footprint. Without any health outcomes, how much the economy could win in the first 10 years if we invest 20 millions. Then, as you can see here, the 20 millions are invested in the 5 years, and then you have a green line, which is the overall economic footprint. The orange one is the direct effect, and the blue one and the rosa, the pink one, are the indirect induced effect that are in the same level. We estimate this induced and indirect effect by consider something that is called input and output matrix. I'm not going to go in detail in that, but the idea is how all those sectors are related to each other. And in the case of Estonia, this is similar effect for the induced and the indirect effect. Then you can see that we have 50 million, the gross value added, for investing is 20 millions in the first 10 years, and we have over 1,000 new work positions potentially created in the market for that intervention. The other point is the social impact of health, the part of the productivity that I told you. In the first 15 years of the intervention, the program will be avoiding 350 deaths and 928 no fatal cases. And that, if we transform that in terms of pay and unpaid work, we have that the win for the country will be over 127 million euros in only the first 15 years. What I wanted also to show you here in these 2 graphics is the unpaid work and the paid work by age category. If you look for the paid work part, then the blue group is those in 60 to 69 years old that is still being part of them in the working age population, and is where we have the higher percentage of events, and that you will always see that up. Then you hit the second group, 7 to 79, that even if they don't have a higher probability of being in the paid work part, they have the highest level of events. No? And then you have the other groups, and then the relationship will be kind of compensating between the probability of having a cardiovascular event and the probability of being in the paid work sector. For the unpaid work, then we have clearly 70 to 79 and 60 to 69 as the most important part. Okay, then this is the short term. We are looking here at 50 years, and if you want, you can also bring the results for the next 2, for the next 3, for the next 4 years. And it gives us also this potential to give a response to how much the country will win in the short term. We can also have that for the long term. Then in this second part of the analysis, we took the youngest age group, the 30 to 39, and if we implement the program, there will be around 12,000 people in the cohort that we evaluated here, and we follow them along the life. How many events will be avoided for this group? How many fatalities were avoided for this group? And we have that for the lifetime of those patients, we will be winning around 20 million productive hours that will be transformed in over 1 billion euros along the life of those patients. Why? Because if you intervene early, the youngest age population is intervened early, is where you have the highest probability of winning. Then we have here both the short and the long term. And this is what I wanted also to highlight here. Then when we make decisions, we need first to give those that have all these biases that are mentioned, there's an additional potential estimation for the short term, but we cannot forget that the highest benefits of health intervention are going to be in the long term. And okay, and what this matter Estonia, I don't think I need to stop here too much because you have already talked about that a lot this morning, but just to say that we need to start connecting labor market with health. Both of them are related to each other. No? Then here, the health sector is also funded by the taxes that are paid by employers. Then if we have a workforce that is reduced, that have disabilities, high percentage of disabilities, then you will have that related, reflected in the budget of the healthcare sector. Yeah, I think I'm going to go to the last part. Yeah, and just very quick, the takeaways that I wanted to bring you today. We need a change in mind, like we have been talking about this morning. Health is an investment, it's not a cost, but this change in mind is not going to happen magically. We need to give metric measures that allow us to understand why health is an investment and how the investment is reflected in short and long-term gains. And we need to empower advocacy. We need also, like someone mentioned this morning, to understand that the budget of the healthcare sector is not just in the healthcare sector, but is a matter of budget at the national level, and we need to speak also to those that are allocated to those budgets and understand their needs. Then, thank you very much for the attention. I will be happy to get any question.
Thank you, Carla. Before we go to the panel, a few questions, Carla, directly to you, if I may. This socio-economic burden of a disease that you mentioned, how is it exactly calculated? And could you perhaps talk us through the formula?
Okay.
If possible. Well, briefly, of course.
Yeah, of course. Well, we have this pay work part and the unpaid work part. The pay work part is looking at mortality, absenteeism, presenteeism, decrease in caregiver, decrease in unpaid work. Then when we look at the pay work, we look at the probability of a person to go to work. No? And we also look at the different probabilities between economic sectors. Then when we evaluate a patient, we evaluate the probability of that patient to be in a particular sector with a particular probability of be working for a specific age and gender. And then we estimate for that specific patient a value of unpaid loss. No, and then you do that for, depending on the epidemiology of the country, of the number of patients that you are estimated to be in there, you do that and summarize that in general. If we go to the unpaid work part, there is something that's called the time use survey that you have for most of the countries. In Estonia, we couldn't find one, then we use an approach, but that tells you how a person is using their day hours. How many hours are for work, how many hours are for cooking, for taking care of the children, etc. And then you can have a percentage that represent how many hours a person of 70 to 75 is using for that particular activity. Then we use the closest sector to value that. No? Then if we are talking about cooking, then you will go to the sector, the dinner, restaurant sector to value that hours. Mm-hmm. That if you don't do that, you need to pay for that. That is the idea behind that. And then we summarize both things, unpaid work and paid work together. A lot of other details, but in general terms, this is how it works.
Seems really easy and reasonable here. Right. Can you use this modeling to calculate impact of other interventions beyond prevention on net financial outputs? For example, impact of particular therapy or procedures?
Yeah. Actually, well, we have both. We have these big prevention programs, but we also evaluate specific programs. And when we evaluate specific programs, we concentrate in the values that decrease the productivity of those patients. For example, if a patient, we are thinking about an intervention and improve the vision, then this patient will have a reduction in the productivity that will also be linked to the reduction in their capacity to move, but also be linked to the reduction in their anxiety of depression because of the reduction in this vision. Then when we look at a specific treatment, we look also at specific variables to reduce the productivity for those patients. Because like I say in presentation, we consider every contribution is important, then every group of patients should also know what is their important as a contributor. No, we give that as a tool for them to also advocate for them on disease. Yeah.
Mm-hmm. Okay. I hope this question is, okay, we have a question from the floor. I'm so obsessed with all the questions coming to Slido because there are so many. Apologies for not noticing you. But do we also have a microphone here? Let me see. Oh, the microphone is actually coming from there to this gentleman over here.
Oh, thank you very much. It was very interesting presentation. I come from Finland. My name is Timo Seppälä. I'm working for AmCham Finland and Baltics also. It's definite that health is an investment and not a cost. And your presentation pointed out very clearly also for the previous presentations. We are now having in Finland this research development innovation program for growth, for well-being and healthcare. And that's part of our government program. I was just thinking that as healthcare can be also, and health itself can be as a growth driver.
Yeah.
And we definitely need growth, economic growth, both here in Estonia and also in Finland. I was just thinking that, how do you see, should we actually combine these forces in Finland and Estonia? Because you are having excellent data here in Estonia as well, just like we are having in Finland. And we are highly leaning on data and technology, AI, etc. So what's your perspective as an economist?
Yeah, well, I think exactly the synergies should be explored, no? It's very important to understand what are the advantage in each one of the countries, but at the same time, like I say, to understand that you need to still see in your characteristics of both economics in separated. I think you cannot directly apply something that is working in Finland to Estonia, like one-to-one, because I'm sure there are many differences as well as are similarities. Then that use of synergies is important. Understanding the differences, that will be, my point. Mm-hmm.
Well, because many Estonian doctors go to Finland, so we share the doctors. Perhaps we should also share the budgets. Estonia would be positive about that. I haven't asked the minister; she would have to confirm this, but.
Yeah, and just to add to that, I think also it's important that we go to the next level, and it's not about just to connect in the healthcare sector that I say. I think we need to involve the labor market as well, to understood that labor market and health goes together, and if we can also apply policies or bring the labor market when we apply our health policies, that will be also bringing an additional synergies to the story. Yeah. I think we have one.
We have more questions. Can you raise your hand once again? So I see you. Okay, you're here.
Hi, Leo O'Neill. I had a question actually but it was to the minister, but I think actually you would be able to answer this as well. Investing in technology versus investing in staff. And where I'm coming from that is we recently were looking at a tender here for home care, and we had looked at the cost of investing in rail system. So one nurse, one carer able to look after a patient opposed to 3. And the feedback was, it's cheaper to just employ 3 people than invest in the actual equipment. Are you seeing that trend that we need to look long term to investing into technology and infrastructure? Because we don't have the population, we don't have the resources. Are you seeing that as a trend, and how important is that?
Well, I think that actually, as a worry that you hear once and once again along the whole Europe, this short in healthcare staff, and one important point is that we need both. No, we need new health technology that allows to have a more efficient healthcare system, but at the same time we need to pay the good salaries for the health. Then the point is how we can combine both worlds. How we can invest in those technologies that allow to free resources and time as well, that the staff can be paying certainly and not being that pressure. We have now a project, for example, there's also the example that I thought before about a drug that comes from the eye. Then you have this NAMD, macular degeneration disease, and then the patients need to go very often to the doctor. Then the clinics are so overwhelmed with the amount of appointments, and there is not enough staff. What have been seen, if we reduce that number of interventions, then the staff we have more time that will be dedicated to compensate and to have more patients to reduce their stress. And I think that is the point. We cannot just look at one or the other, but we need to look at the interaction. If you are going to invest in new health intervention, you also need to see how the new intervention is going to affect the level of requirements for health staff and how much not only cost savings, but how much time can be liberated for the healthcare staff. Yeah.
Thank you very much. I'm afraid this is all the time we have for this part of the conversation, but the conversation will continue now on the stage, Carla. So if I may ask you to already take a seat, and I will invite the rest of the panelists. Now, you have heard strong evidence that investing in health can actually add years both to healthy life and return significant value to the economy. Now it's time to really bring those perspectives together and ask, well, the harder question: how can we turn this evidence into real policy and real action in Estonia? So please welcome our panelists. Carla's already here, but I would also love to invite onto the stage dear Minister Karl-Hendrik Peterson from the Estonian Health Insurance Fund, Ahti Kuningas from the Ministry of Economic Affairs and Communication. Alex, please take a seat. And yes, that's our panel, actually, ladies and gentlemen. With your applause, it's good to begin. So, Minister, I mean, you also referred to the recent report of the Foresight Center saying that Estonia's healthcare system, as everyone know, isn't financially sustainable. Now, how can we really fix that without changing how we fund it? And what changes in policy do you actually see, looking and hearing from this evidence that, healthcare is not a cost, it's an investment?
Yes, the same report actually gave several suggestions how we could change the budget of healthcare. And my policy has always been, even before I became a politician, that we should not just put money into the healthcare sector, whatever the sum would be, but we should look into the expenses where we have the biggest expenses and where we have biggest losses and also where we have biggest gains. And we should think strategically how to spend the money we have. And of course, also we today saw the percentage of GDP in Estonia. It is lower than in EU average. And I am sure that we need extra money. And I have said it loud too.
But through which kind of reform? What kind of funding reform do we actually need?
Well, I will tell it after we have done some more research.
So not in this panel?
No.
Oh, that is unfortunate. That is unfortunate. Ahti, now that you've also heard all of the speakers before, do you believe this research? showing that every euro invested in healthcare will actually return several euros to the economy. Does that also apply to Estonia? And if yes, then how could the Ministry of Economic Affairs help turn that evidence into real investment priorities?
Yes, now I believe after seeing the presentation.
Thank you.
First,
that's what I wanted to hear.
Headline was a bit misleading that we just pour money and then all the results come. But
now you know how it works.
Now I know.
So how do we make that happen in Estonia?
That there are some areas what to prioritize and some areas where to find cost effective. Misleading was this part that we just look this OECD or EU average and we should tend there. But we know that some of these countries or most of these countries actually have quite stress in their budget. So actually we should look maybe some other examples. And I found, for example, okay, they're not so comparable, but in other areas we always compare with them how to do, for example, innovation R&D better. Israel, Singapore, Taiwan, they all have something, health expenses 5 to 7% of GDP. And actually the life expectancy and also these healthy lived years are the best of the world.
So we don't need to increase our budget?
Budget increases by itself anyway, we hope, when the economy raises, but we should seek better means how to use it, yes.
Right. Karl, I mean, you have quite a challenge with the budget. I mean, the deficit is clearly there. Now I wonder, if there were no, let's say, bureaucratic or institutional limits, how would you allocate that same budget differently to achieve a much higher impact? I guess you have a few ideas.
Yes, we do have a few ideas. I'm not even quite certain that the existing legislation is that much of a hindrance.
What's stopping you?
It is practically defining the new model how we pay for value in healthcare. So I think this is one of the things where we first of all have capabilities. As we know, Estonia is pretty well equipped with healthcare data, but we need to pull that data together so that we are actually able to use it to define those new methods in terms of data. This is work that is ongoing, I would say. On the other hand, I think there was a mention that not all money that you are investing is actually in an investment. So we should be really concise about where we put this money that we either get from the growth of economy or through some other means.
Are we wasting money somewhere right now?
I wouldn't call it wasting, but I would say that there are better alternatives for the money. That's let's say.
I mean, we're having a private conversation. I mean, no one would mind if you point out a few places where we could get a better.
Well, I can say we are wasting, yes.
Where?
In several places.
Well, you can have this discussion now. I'm very curious.
For example, we don't follow up. For example, if a patient goes to visit a doctor, we don't evaluate if the decisions made are based on diagnostic criteria or recommendations, and so on. If the treatment is of high quality and so on. So, and sometimes, actually, by statistics, a third of patients in hospital visits, I mean ambulatory outpatient visits, they are not in the right cabinet or office. They should be at another doctor's or maybe a physiotherapist or psychologist's office. This is only one number, and it's about 500,000 visits a year.
How much money are we losing? What do you think?
It's about 20 million a year.
Yeah.
No, we're not losing, we are displacing it.
Okay,
the wrong place.
Karl, but you're fixing that. Any other ideas?
Yes, we know that data that Minister taught. So we have a project that has been initiated to actually tackle that specific issue. But for all of those projects, of course, healthcare is a delicate balance. So even though we could perhaps enforce something with high speed, then we should be careful not to break something along the way. So what else? I think what I heard here that was quite interesting was definitely, first of all, the prospect that we shouldn't just look at the healthcare cost, but the wider value chain. We are, of course, aware of that. We have some good discussions with also people that are here, but there need to be taken steps that we are actually able to price, to show our projects, show our initiatives in these terms, that what is the wider impact to the whole economy and lives, actually.
Maybe I will just add what they are actually doing. It's a very, very good thing. It's a data-biased decision system, so that and also integrating AI into different processes and analysis and so on, so that we also can start value-based financing and those better methods.
But Karl, that's clearly not enough, isn't it, to get out of the 200 million deficit? You need a more dramatic reform.
I like the thinking of if someone has read those books about innovation that are quite hot topic these days. One of the newer innovation dilemmas or innovator dilemmas is that when you have an existing system and you have a new challenge, should you change the existing system or should you build something alongside of it?
You should put more money in it.
Yeah, but the question is, how do you put that money into action? So for that, if we are building this value-added pricing methods, then I think this is a point of discussion and thinking that whether it should be as a new additional, which means it will require new or additional money, or is it going to, let's say, cannibalize from the existing budget? So this is going to be an interesting discussion. I think we have also seen that globally there have been some interesting ways of raising money. For example, social impact bonds, which could be actually a good way to approach investing in this type of activities.
Right. Yeah. Alex, I guess many countries say that, well, we simply can't afford to increase investing in welfare, in healthcare, sorry. So when we're talking about really increasing the healthcare funds, from your global experience, I mean, what has to go wrong for this claim that we can't afford it to be true, when every euro invested in healthcare will bring back much more to the economy? So what has to go wrong for this money to be invested in a way that it actually goes to waste?
Yeah, I think that's the way it can easily go wrong is when actually the investments are actually not really investments. They are just more budgets to be able to continue the operations the way they exist today. And that is, like, unfortunately immensely classic, where it is different on one end to run the operations and improve the efficiency of the operations. And I think in that sense, our industry is not that different than many other industries. So running efficiently the current operations is a different topic than investment. And I think both of those things are at times opposed, but I don't think they should. So running efficiently the operations would be one thing. And then you invest typically for two reasons. You invest to decrease cost or to increase revenue. If I take an analogy of a company, you would invest, for example, to decrease cost. And we heard two things just before. I mean, I'll leave it to your good judgment which one matters the most and so on. But like we heard about value-based care payment, and we heard somewhat the idea of more of a care navigation hub. How do you make sure the right people are in the right queue at the right time? So in order to have those capabilities like value-based care payments or a care navigation hub so that people, again, are at the right place at the right time, it takes an investment. The output of that investment is actually more directly tied to how do you optimize the operations and your cost. And that's an investment into productivity, which is fine. And there is our investments to increase revenue, which is in that case, you could assimilate that to an investment to increase healthy life expectancy. And so ultimately, you are increasing lifespan of the population and health span and get a return in GDP as well. So I think what I unfortunately see going wrong quite often is mishandling and not ill-intended, but into like all the money goes into one bucket and runs for the operations. So I think it's more, what is the budget for this, the budget for that, and what do you expect in terms of return from each money which is being put in each bucket?
Anyone wants to react to that?
Yeah, I can react to that. I think what was clearly shown on the slides that in a way we have a demand problem in healthcare because the demand is just rising and rising and rising. And unless we are doing something differently than adding new money to that same system, basically prolongs the issue further down the path. So this is why we need to change our thinking. This is why we are talking about new payment methods. And not that the old ones are bad. They're not bad. They're part of the game, but just we're missing some parts in the whole puzzle.
Like what?
Like, for example, this value-based payments. It's clearly missing today. It's not fully missing. We have some examples where we have built those, like this is the stroke patient pathway, for example, that is currently running.
But it's just one project, right? And what's the proportion of this value-based funding that we should actually reach to, and in which time frame, do you think?
Why we're talking about data and AI and other methods is because having run those pathway projects now, 6 of them, it is quite clear that for one path we need about 5 to 6 years to implement it. That's a very, very long time. And it just doesn't scale. It is the correct solution for some specific cases, but in this specific way, it does not scale. So we need a different pathway to define those basically value metrics to these healthcare services. And this is what we are now have a running hypothesis that we can do it using empirical analysis of our existing data, plus AI solutions that have been also recently published in, for example, Nature.
Ladies and gentlemen, I really appreciate you sending a lot of questions to Slido. I have to apologize in advance. I will not be able to take all of them because we have roughly 9 minutes of panel left. But one question to the Minister, speaking of innovation, in the scale from 1 to 10, how satisfied actually are you with the current state, with the current access to healthcare innovation in Estonia, and why? And what are your priorities?
It actually depends on what do you compare us with. If you compare us with some other countries, then I think Estonia is digitalized, innovative. I cannot say that the others are not, but we are really pioneers in many ways.
We're the most digitally advanced country in the world. Let's compare us to ourselves and our healthcare system to our other digital solutions.
I was about to reach that.
Sorry.
Yes. So we have developed a lot. I have been a doctor more than 20 years. I started with pen and paper, and now when I had my last days, I had no pen and paper on my desk. We started with people coming only because they needed prescription. Nowadays, they just maybe wake up early in the morning. Oh gosh, I don't have enough medication, and they just send a message via very secure channel to family doctor, and they will have sometimes the prescription also in some hours in better facilities. But my priorities I have 3 key priorities when I started this job as a minister. And the first was really funding, what we are discussing here now. The second was how our healthcare network is working. Where should be the hospitals situated, what kind of services should they offer, and the same for family medicine centers. And the third is quality of care, we have not actually talked a lot about it here today, but the quality of care is actually also something that is cost effective. We really lose a lot of, well, also money, but actually we lose health, the life years and healthy years because of very changing quality in the healthcare system. And we have started, actually the previous minister started it, and I will very strongly continue it. We started the quality system which covers all Estonia, so that we can develop measurable, as you said, you cannot change what you don't measure. It was a very good sentence in the end, that measurable parameters and so on, so that we can really strategically invest money into health. That's my goal.
But I'm going to rephrase the question. What are the biggest challenges for the following years for the ministry to overcome in terms of data and digitalization? Because that's, I believe, the core of the question that was asked.
One of the challenges is that we are pioneers, because we started digitalization more than 20 years ago, and many of the systems are based on IT that is old already. Nowadays, while we are already talking about introducing AI, which is also maybe 3 years old, and we have to implement it on old systems some way. So we have to regenerate and renew the IT and digital systems. And thus, actually, many countries who have been our followers have done many things better because they could learn from our mistakes, and so we can share experiences. I think this maybe, and also the legislation, Estonian digitalization has been so successful because we had really strict data protection. But nowadays, we need the secondary use of data. We need it to use it for science, for analysis, financing, also for quality of care, etc., and also for helping people understand where they should change their lifestyle or something. So we need to change the legislation too.
Ahti, in Finland, as we already heard, the government has an R&D and innovation growth program that really relies heavily on data and technology, and it explicitly aims to make healthcare as the new driver of economic growth. So what do you think, should Estonia consider adopting a similar strategy?
Yeah, a lot of things we are adopting, probably. We as a Ministry of Economic Affairs, we look at input, healthy labor, and output, how to export actually everything. And if they export and to R&D, then it can be used also in Estonia. But we have two things in cooperation with Ministry of Social Affairs. First, apply the research center, which is right now making this priority area, or it has already, but building it up for adding value to all the data but the medicine sector has. How to bring those together, look at the legislation, how to open the data, like Minister told. And then a third pillar is how to make it usable for the companies, but also to doctors to prevent diseases and also R&D. And this is the first thing what we are looking into. The second thing is that we are financing either startups or mature companies in different areas like deep tech, but also production facilities. And for that we have special program, and it's also dedicated for medicine in our R&D strategy, one of the priority areas. And third thing is that if anybody wants to build up a factory here capacity, then for that we have now even larger sums thanks to the new government.
So a question from Slido: how do we implement the value-based healthcare decisions into real life? Concrete, what are the next steps we need to take?
I think Karl is better to.
Yes.
Hi.
So I mentioned that there are different ways to actually define the potential value of a specific intervention. What we are currently investigating is changes in person's risk profile. So for example, if we are predicting that for this person, given this data historically, their probable health pathway cost is going to be X. And using empirical studies, we are able to basically categorize different pathways. And if we see that the person by themselves or by the help of healthcare service provider is actually going to a new path which is cheaper, then this is already actually concrete value that we have a net present value defined for that specific new pathway. And this can be shared, this net present value. It's not direct sharing. There are, let's say, financial wizardry in there because the pathway is calculated for over a long time, and this long time includes risk. So that has to be priced, but practically it's doable this way. And I think it's also, I know that there are multiple cases in the world that are using the similar method. We are, of course, looking into those, and I know Alex talked yesterday about interesting insights into those things. So this is where we need to also learn from what others have done and how they have done it, so that we know what works and where to be careful.
Minister, someone from the audience is very kind to offer a very specific service. If you could have one wish, and it's not a goldfish, I can tell you, it's a person, because goldfish don't type on Slido. If you can have one wish to AmCham to coordinate or fund an independent study to analyze problems and solutions, in which area should it be?
It would be digital innovation and secondary use of data, and also how we can use the things in digital world we already have to make it better use for Estonian people. Maybe that area, and also how to cope with the legislation problems, because changing laws sometimes takes a really long time.
Carla, you've been listening very patiently, and I appreciate that. What's missing in this conversation? What are we getting wrong?
Well, the last part, I will not be able to answer that. But what I think is missing is, well, like an anecdote in another forum that I was, and we were presenting that as well, a person, the country invested in reducing the queues in the hospitals, no? And there was 100 million euros, and he was asking me, can you, in your metrics, tell me when my 100 million euros are going? No, because you shouldn't think about that before for any 100 million euros. What I think is missing is this follow-up of what is going to happen after the investment. We need really clear KPIs that tell us where this money is going and what is the effect of a particular investment is. No, is like we already say, first we need to establish priorities, what are the needs, and then we decide how much money will be invested in the need, and then we need to measure it. No, if that is actually working. And I think this is the thing that I'm missing here in the conversation, this follow-up. No, and that should be a very important stone also in the process to make sure that all those projects
that actually links extremely well with one of the questions that again has been posted on Slido. Should there be concrete quantifiable goals, like let's say a 30% decrease of cardiovascular secondary events, let's say by 2030, for health outcomes to remunerate providers when funding healthcare? Is this one of the specific benchmarks that we should set and start funding accordingly?
This is the core of value-based funding. And Carl didn't mention one of also biggest projects, which we have actually had more than 10 years. We have with family doctors, we had this project where we collected, so to say, collected all the patients with chronic diseases and set up how to follow up those patients. And the doctors who had done those procedures gained some benefit. But we actually should move forward and start measuring the same value. It's not important for how many times you have given blood sample or have been taking medicine. For a person, actually, it's important how the life is. Is the blood pressure normal, the values of maybe cholesterol normal, and so on. So we should move maybe a little bit more forward and measure value, real value.
Alex, when you hear how we fund our doctors and the procedures, it's volume based, right? What's your recommendation? How to move forward from that to really get to value-based? Because I understand not all providers, not all hospitals are super enthusiastic of taking that leap.
Yeah, I mean, I will let policy decisions to the people that are in charge of making those policy decisions. I'll afford, but I'll provide more insights on what I'm seeing in other countries. Mm-hmm. I think the countries I've seen and I've worked with related to their transitions from typically we call it fee-for-service or volume-based towards value-based care payments. I've seen like two different angles to that transition. First of all, this is a transition step by step. This is not like one or the other. Those are like specific slices that are being like moved from fee-for-service to value-based care payment. I've seen a lot of episode-based systems whereby you would have an episode like as simple as asthma exacerbation, perinatal episode, like multiple episodes like that, or hip and knee replacements. The ones that are the most codifiable and the one where the pathways is the clearest and where you have evidence on what is a normal cost for those ones are the ones that are being packaged as one entire end-to-end pathways and that are being then procured by the national insurance towards the provider and where the delivery is according to results versus just the individual services. So episode-based payment has been one direction I've seen. And the other one I've seen where things called like patient-centered medical homes or more primary care type of bundles. And here in that case, you're talking about capitation arrangements. So I don't want to enter into too much of the sophistications of the payment models, but like this is a transition step by step. Many countries have been through that. So here I would argue the interesting advantage is there's been about 10, 15 years of evidence of those types of transition that I would argue here Estonia can benefit from.
Excellent. Ladies and gentlemen, you've been patiently waiting to use your voice to phrase questions. I see at least one hand up. Can we provide this lady a microphone? I believe it's heading your way. And a gentleman over there. So we can use that last 5 minutes. Fortunately, time has been added to our panel. So we actually have 5 more minutes left. Maybe I was looking at the clock wrong. So go ahead.
Thank you. I'm Liudvika Sterkienė, and I'm from AmCham and from Lithuania. So first of all, congratulations to AmCham Estonia for leading such a high-value discussion on healthcare and how we can do better. And I have a question to the minister, which might be a simple one, which might be also a complicated one. So as one of your priorities, Minister, you mentioned funding. So knowing that, unfortunately, terms of the ministers in the office are quite limited. So what ambition do you set for yourself that after you close the door of the minister, of the office as a minister, you will say that I have accomplished what I had aspiration for?
It's a very good question, and I have asked it also from myself, especially knowing that the ministers, well, as a minister, maybe I will not follow, will not continue. Maybe it can be ended within a day or two sometimes in some political cases. But for me, I think at first, I think I have actually done some things. we have had a really good cooperation with the Health Insurance Fund. I have strengthened the leadership and also the same report I mentioned, which was published recently, gives many ideas. And I think I can answer the question really in maybe 4 months when we have done the analysis, calculations, and I have come out with specific suggestions. And when we start with state budget negotiations next summer, I really hope that I will have at least 1 or 2 recommendations where we can invest in healthcare with measurable results. And maybe that would be the start of changing the way how we look at healthcare costs in Estonia. I hope so. I hope that it will be not only the message that has been given so far that we just need the money. It's not only the money. We need much more than money. We need strategy. We need personnel. We need also motivated patients. Thank you.
So we had a question from a gentleman over there. Go ahead.
Edward Laane, Kuressaare Hospital. So thank you all for a very exciting presentations. I think medicine in Estonia, when we look health, it's quite good. It's not bad actually when you look overall in Europe or in the world. And during recent years, our life expectancy has increased, and I think it's improvement. But my question is, if I looked correctly, that in Lithuania and Latvia, the other parameter, what you lived in pure health, you have like a worse health. Yes, in pure health, it's better in Latvia and in Lithuania, but we came from same background, and I think Estonian economy is not worse than Latvia or Lithuania. So what is the difference? Why we have a worst outcome in these health parameters? Does anybody know? What is the secret?
I certainly don't know the answer, so I'm looking at the panel.
It's a difficult question because, well, actually, it also depends on parameters what we look at. Yes, if we look at just life expectancy or healthy lived years, it's a very general way of looking at health data, but our also the financing of healthcare are very different in these countries. I cannot give the answer why one thing is better and one thing is not. For example, our tobacco policy has been really effective, and alcohol policy too. Latvia just is catching up with our alcohol policy. Maybe there are still some cultural differences. I don't know.
They drink more and live healthy longer.
I don't know if they drink more.
That would explain the Finnish statistics as well. Do we have another question from there? Go ahead.
Dr. Grace, Medicum, aktsiaselts. I have a question to Minister. You prescribed to us picture that we will get more abortions, and we have to keep in mind that people in older age are very active and have good quality of life. And at the same time, we know that they take a lot of pills for having this good quality. And do you believe that this situation is possible to change without changing system or without changing principal things like a management and or whatever could be reasonable? But I have to say that in Estonia we too much think about having money and getting money. That if you think about security and military support now, what we do, we buy weapons, but we do not train people. And you, in your talk, mentioned that digitalizing could be a solution. But at the same time, we know that older people are not familiar with that. What we can change, what we can do for for solving this Estonian critical situation? Thanks.
Well, I think the answer could take some hours of discussion.
With 2 minutes, if I may.
That's almost the same. Yes, what we can do, of course, we cannot do anything. We don't change the system. Again, the same thing that if we just pour in money, we are speaking also today a lot about money. We cannot change. We have to change the view of how we keep people healthy and able to take care of themselves for a long time. In Estonia, we have started to make stronger the cooperation between social system and the healthcare system. And actually, also we should include communities to take care of elderly people, to help the people in need when they are even not older. We actually should start with education because we know that the higher the education, the better the income, the better the health. It's a universal rule worldwide. So it's actually a question for whole government. It's not only a question for Minister of Social Affairs.
So perhaps we wrap up this panel with a question at the very core of this debate that we're having. Ahti, what would it take really for the Ministry of Economic Affairs and Social Ministries to really plan together to treat health, innovation and productivity really as this one system to really get health integrated into our national competitiveness agenda?
Yeah, we made already this memorandum of understanding and looked what we do together and what we have to do separately. But I come back to the beginning. I brought these 3 examples, Singapore, Taiwan and Israel. And actually they are not this kind of very distant countries like US, for example, from our system. They have similar elements. But what the 3 main pillars, first is competition. How they bring competition with good metrics and how to measure things. In Israel, they even have 4 health funds to make, and they are all state-owned kind of.
So we just need 3 more health funds.
And but they compete. They have discussed it if to do 1 or to keep 4, but since the competition makes the prices so much better, then this is the solution. The second pillar is prevention. All in their metrics, but also in this competition, they put a lot of effort to the prevention. And the third one is digitalization. If Europe generally is not good in digitalization, then those 3 countries actually are. They have also data, but they have managed now also to take it into use to make all kind of prevention and this life. How you explain it? That to see what is coming for the people and make some more tests. So I see that many things are on the work. First, this competition part, kind of also in your system. Then we do all together this digitalization, look all over the regulation through. And I think the prevention is the most hardest task to do. But if those 2 are in place, then probably the third one comes itself. Not itself, but with a big push.
Dear panelists, thank you so much for this discussion. Unfortunately, this is all the time we have. Ladies and gentlemen, applause to the panel. Dear friends, ladies and gentlemen, welcome back. I hope you feel refreshed and inspired to continue the discussion. Now, the next report is actually something that we've already touched upon. I even borrowed a few of its findings in the previous panel, but now we'll hear directly from the source. Kaupo Koppel from the Foresight Center will walk us through the main challenges of Estonia's healthcare system, what it faces on the road to 2035. The floor is yours.
Thank you very much. Here we go. So yeah, we published this report 2 days ago. So far, really well received. We have 83 comments of what is wrong with it. And if you have anything to add, then feel free. So we're going strong. First, we're gonna go with big picture of where we're at 25. I know you discussed it a bit, but where we are is an important way of discussing before going forward. So when discussing healthcare, we are discussing about 3 billion euros in a year. Estonia finances is approximately 7.5% of GDP. This is less than Europe. This has always been less than Europe. This difference means about 1 billion euros a year. To bridge that gap, this is unlikely. The main source is obviously public sector and health insurance fund. The main source of health insurance fund is social tax. Voluntary payments, private money is very rare. Out-of-pocket payments contribute more than a fifth. This is quite a large share. We would like it to be approximately 15. We're above European average by far. Out-of-pocket payments are definitely a problem. One of the main problems in Estonian healthcare. So I understand you've seen some of those slides. We're not looking at happy next 5 years. So there are 2 predictions within health insurance reserves. They will either end at 25 or 2030 based on tax revenues. This is better than the last prognosis. So we're going upwards. The plans for how to save this money, how to actually reach 2030 are still largely undefined. There are some discussions. Some decisions have been made, but definitely not all of it has been actually decided. So why are we there? I'm gonna talk about costs before going forward. So Estonian healthcare costs have tripled in the last 15 years and doubled in the last 10 years. This is mainly due to price and wage growth. Over half of this cost increase is due to prices and wages. When going there, this is mainly due to salaries of healthcare workers. We see that salaries contribute over 70% in nursing homes. This is definitely a largest share. About 40% is explained by more frequent use. The healthcare services are more complex, there is more demand, but actually population growth and aging so far contribute less than 10%. We see 5 and 3% in the last 10 years. This is expected to increase a bit, but it will never be the main driver. Population aging will never be the main driver of healthcare costs. While the salaries have increased, this is mainly a good thing. This graph shows our nurses, our doctors, and migration, the net migration, yes, that was the word. The net migration to Finland, to other countries, it has decreased tenfold. So 2020, we had 400 medicine workers leaving Estonia. Right now we have 40. This is an excellent result, actually. When discussing healthcare workers, we know that there are several forecasts saying that we're missing, in 10-year perspective, we're missing 700 nurses and a bit less doctors. So this is an actually excellent result. What more about workforce? We know about labor shortages, mainly nurses, but also family doctors, psychiatrists, and other mental health specialists. We also looked at those salaries a bit more in detail. We see that public and private share healthcare workers, they earn they're comparable before when looking at full-time hours. But since in public sector, the staff works overtime, it often works overtime, and those overtime hours have increased. We see larger salaries in public sector so far. This is also a trend of recent years. The wage increase. So this graph explains where we are at Europe when we compare our wages of nurses and doctors to the average wage of this country. We can see we're in the middle of European. So while the salaries have increased faster than other salaries in the country, I think we've reached the point of we won't see an extended growth so much as we have seen in last years. The salaries will continue to grow, obviously, but not in the pace of 10% a year or 9 or 8. We are approximately where we should be, I think. A bit about infrastructure. So half of Estonian hospital network is more than 30 years old. This will need investments. When buildings get older, they tend to be more costly. On the graph, we see the blue line is total investments to infrastructure, mainly buildings and mainly hospital buildings. The red line is how much of this is EU funded. This is actually a trend to keep an eye on. EU funds at this rate will end at 2027. We're not sure about the new period starting from 28, but if we have more than 100 million a year funded by EU, then it might not be as big funding from the EU in the new period, which means we will need to find new funds to build our hospitals, to renew our IT, or not do it at all. But this might be a problem since well, half of the hospitals are more than 30 years old. What more, the IT expenditures. To keep the same level, we would need approximately 60 million just to go on. There are parallel, I think 4 parallel systems in Estonian healthcare IT. So to keep this, to sustain this level, we need 60. To improve this, we need from 100 to 200 million in investments. This will bring us back money later, but before it brings us back money, it will obviously take some money. So solutions, perhaps more interesting. So the panel already covered much of this value-based healthcare. True, in Estonia we have mostly fee-for-service. So when you go to a doctor, he or she takes your blood pressure. This is X. Takes it 2 times. This is 2X's. This does not go along with efficiency much, and the science also shows it. Well, value-based models, we have looked at 3. Those are those episode payments. They work well in surgery. Like you look at the whole surgery progress. This is a bit concrete. This is might work. Disease-based payments are more connected to chronic diseases like diabetes. Here, the WHO, the World Health Organization, is more critical for it to work. It is very complex, actually, to make all of chronic diseases fund, and the funding of this medicine work. This is perhaps the most complex one of these. And then the third model is population-based funding. Usually capitation-based might work, has shown some results. The main challenges were discussed a bit. Data sharing, data exchanges. We are at the forefront of IT, but even we will have major issues actually connecting those databases. Seeing live data, seeing close to real live data, this is very difficult. What is known from academic literature, the healthcare staff might not be too optimistic about these models. It increases variability to the budgets of hospitals, to the budgets of family centers, which is again might not seem that attractive to those actually doing those procedures. So the graph is a meta-analysis looking at value-based healthcare matters. So Europe world has experimented with those more and more recently. Yeah, I will need to translate some of those. Those studies are not consistent at all. While we know this 96% is 96% of studies have seen some kind of better results, like 1 or 2 indicators went up, or maybe we saved some money, some kind of, which is a good thing. Another that is 36. This is decreasing costs. So while introducing value-based healthcare, only a third of studies, a bit more, have seen cost decrease. However, 4% have seen neutral and less, and others have just not measured it. So these studies are often inconsistent. The last ones are patient reports. 25% have seen patient report decreasing, good. 11 have seen it stayed the same. And the very last column is 51% the costs were measured inaccurately. So we cannot actually say what happened. So this is about how to find new funds. Turns out, since Estonian healthcare is very much workforce financed, we depend over 80% on social tax. It appears then when we work more, there is also more money. I will go over the graph again, which is in Estonian, so sorry about 1% rise in employment adds almost 30 million to the social insurance funds. This is a very large sum. However, it might be even more difficult to increase this. Estonian employment rate is one of the highest in Europe, especially our elderly employment rate, and ages 65 to 73. I think if we're not number 1, we're number 2 or 3 in Europe. So the elderly workforce works very, 1/3 of elderly work in Estonia. But yeah, we can see that 1 percentage point equals almost 30 million. There's more money in younger worker groups. So the other triple is if we increase the pension age. This will, let's say 2 years, would bring health insurance fund about 30 million. However, this is unlikely. Definitely politically challenging. And the last 6 is when the immigration increases. We can find additional 20 million or up to 50 million if the migrant salaries 2 times Estonian average. This is very ambitious number, this 10,000. We know the migration numbers are lower than this, so we can look at this over several years. Let's say if we can have over 3 years 10,000 extra migrants with this salary, then this is, over 3 years, this is still a decent amount of money, I would say. Then obviously, I will come back to it later, the private funding. From left to right, we have axis explaining healthcare expenditures as of GDP. Told you before, it's about slightly above 7 in Estonia, which is lower than the average. From on the top to bottom, this is how much private fundings contribute of all healthcare funds. We can see Estonia nearly at the bottom here. This is a small amount of money. I've circled Croatia, Slovenia, and France, which I will come back to later in the scenarios as a possible examples of where to get private money more. So these are not our usual Finland or Sweden or Germany, but rather unique models in Slovenia or Croatia. So the scenarios. First, how we got those scenarios. So these are just not these are not fantasies. They actually are work of results, research results. So knowing all this, what I've discussed briefly, some trends emerge, and some of them are more important than others. There are 4 main factors that influence Estonian healthcare in the coming 10 years. So this should be looked at as 10-year perspective. This time in Foresight, we tried to be more realistic. Usually we do those in 2040 or 2050 perspective. This time, knowing we have imminent crisis with the reserves, knowing the difficulties in foreign policy, and also knowing that currently no major funds will be allocated to the health insurance. So we took those assumptions, mainly those last year, and we tried to look at those main factors that will influence the healthcare in 10 years. So those four are, it's public attitude and political attitude towards the solidarity principle. Solidarity meaning the healthy will fund the ill and the young will fund the old and so on. This has always been at the core, one of the core principles or the core principle in Estonian healthcare. It can either decrease, it can stay the same, or we can decide that yes, we actually need to make the solidarity principle stronger, either by reducing out-of-pocket payments, let's say. The other trend is labor market conditions. We saw the influence of tax increases is large, but we also know that platform work, one-man company work, they're all influencing the tax revenues. Factor number 3 is price pressure in healthcare. We saw prices, and the increase of prices is the main driver of healthcare costs. So we can see those costs coming down, we can see those being stable. Let's see. Depends very much on the global economy. And last, it's society's trust in technology and the readiness to apply AI. This is perhaps the most variable of those. We know the trust in AI is not yet that high. Different studies say different things. We rely on those that say 30% actually trust those AI decisions. So we can say that yes, the AI jump in education will go well. Let's hope it will. This will definitely increase the trust, or we can just call it an AI boom, which will not lead anywhere. So the 3 scenarios. So this is the 10-year perspective. Here we say that the economy is going stable. It's not increasing by much, but it is also not increasing. So the cost will still continue to outpace the economic growth. But no one wants to increase taxes in this world. Instead, we believe in, Estonian has always believed in technology. So here we lay on trust in technology. We decide that, okay, it will bring us back the investments in 10 years, then this is appropriate, yes. So in this scenario, we will fund the AI jump, we will fund the technological jump. This will cost us a lot in the beginning. But first, health insurance fund needs money to sustain this in 10 years. We'll need money to buy just measures for the technological measures to bring us back money. Here we're looking at the integration of hospital and primary care information systems. Again, tens of, if not hundreds of millions of investments. But on the smaller scale, we include AI-supported decisions tools, automated documentations. We check the science. If AI documentations will save 1 minute of patient time or nurse's time, then since we have roughly 13 million patient visits a year, this saves us more than 60 full-time doctors in a year. So this is, again, a large number. In monetary terms, up to 10 million, fully by automated documentations. Then e-consultations, approximately the same monetary return and so on. Personalized public health, so we lay on trust on AI. However, not just AI. Here also some value-based elements will be included. So this scenario is mostly about finding new efficiency. Not so much finding new funds, but finding efficiency within the systems and reorganizing it digitally and value-based. The impact will rely on the readiness to use AI. Since we are ready, possibly good, but health inequalities will increase. We know that digital readiness, the digital competency is not uniquely in society. The IT investments will save money in the following years, but not immediately. This return will come in 5, 6, 7 years. In the long run, good. In short term, there are major problems with data exchange and transparency. Linking quality indicators to funding. Well, this creates a lot of variability and uncertainty for providers. We played around mostly with linking the patient outcome or patient satisfaction to the funding of hospitals or first aid. So let's say when the average is to 85, we can say that if you're below 80, then you lose 2 or 3%. If you're up to 90, you get 3% more or 5. The bonuses need to be bigger than the minuses here. This is perhaps the most positive one of the scenarios due to the fact that first the health insurance fund will get a lump sum of money, but the efficiency here will increase in long terms. In scenario 2, we decide that yes, market is the option. Yes, this is challenging, but the patients are required to pay a larger sum of healthcare costs out of their pockets. So we decide that to save Estonian healthcare, we decreased out of money the health insurance fund pays. If now most services are funded 100%, we can say that, okay, health insurance fund now does 90%, and we save 10, but this 10% will go to the patients. The patients will then have to turn to insurances, and that will be the scheme. Employer-paid insurance premiums will take account sector-specific risks. So this will lead to more money, obviously. Every 15 years, let's say a patient has to pay 15 years to insurance, this will lead up to 180 million per year to the system. This will solve the problems in macro terms. However, out-of-pocket payments will increase significantly. The system becomes fragmented, which is perhaps the main issue, forming 2 tiers. We have the private tier, where the people who can afford this can go to the doctor more quickly, receive good help. And then there's the other, rather underfunded public sector, where there are the elderly and those not be able to afford those. We can also see from there's empirical results that this will accelerate movement of healthcare workers to the private sector. Where today we see that 40% work in private, this will accelerate the trend even more. We suggest up to 50 may reach private. Yes. And the last and the least, this is too little too late. This is where we do nothing. This is where, not nothing, but this is where we do small things. We hope the crisis will go away. Since the newer forecasts are more positive than the previous ones. Previously, we talked about in the year 2035, we see 700 or 900 million in minuses. Well, those models have been improved. We only see 100. So we're going to make some decisions, like we're cutting costs or in radiology, expanding the role in nurse practitioners. This all will increase efficiency, again, saving us 4, 5, 6 million a year, but not 100. We know that elections are coming in 27. Not many decisions are made before elections. After the parliament, who knows what the parliament will be? We can see perhaps there are even more variety in parliament in what to do. Should we increase taxes? Should we go to private? Should we do AI? Here the undecision is no one will decide up until the point where we actually are out of reserves or very close. Now this is the worst result actually. The the trust, obviously, to the healthcare system. The solidarity, the trust will go down. The trust in solidarity will decrease. Healthcare continues to face structural underfunding. We have reached some efficiency due to those measures there, but the structural underfunding is still there. Hospitals will start to not receive the full money. They will struggle with backlogs and equipment renewals. All this IT, this will still not be renewed. The hospital buildings are still not being renewed. So this will all reach the public health, and the quality indicators will start to increase quite rapidly. Workforce shortages intensify. We cannot afford to do wage increases in the pace of before. The wages might be made stable. Public dissatisfaction obviously grows in this scenario. And while at the point of 25, 35, obviously this cannot go on further, so political consensus has to be reached at this point. So there are measures, we can appoint 30 million to the health insurance fund. We see that temporary tax rise will be implemented in 2030, 2032. The health insurance contributor is aligned with income base. Right now it's not, but this will bring up to 200 million in those 3 years. This will solve the imminent crisis, but again, the imminent crisis will then go to 35, 34 years, so we will again postpone it, but not actually make something better. Larger decisions are not made, permanent transfers are not made. All of this will make trust fall. All of this will make, this doesn't make a lot of things better. So any kind of decisions is better than not making any decisions here. I will summarize in 4 choices. So the most consistent one with the science has any health econometrics academic will say that the best thing is actually broadening the tax base. It brings permanent increase. This is the most efficient thing. However, this means direct tax rise or increasing the tax burden. Not very popular, also does not make the system more efficient. We can promote private insurance. This will bring new funds. It most likely will. However, it most definitely will increase inequality and increases the movement of healthcare workers to private, which again might lead to new problems in near future. AI investments and digital solutions are likely to save the labor, shorten waiting times. There are some good things there. However, like I said before, it's the most variable scenario. We don't quite know. The pluses are big, the minuses are unknown so far. Potential long-term gains are good, but investments in the short term are bigger. And this also requires risk management and strong and clear data protection. We can see data protection trends getting more strict. Perhaps they don't align with this scenario that much. And last, it's the value-based healthcare models. We suggest moving towards that directions, linking funding to the health outcomes, promoting collaborations. I guess all sounds good. It's very difficult. This will need systematic shift, and it's very difficult to actually implement. It sounds good, but it's actually very difficult. However, the bigger scale is better here. Science says that the bigger scale is better. You need to measure more things, so the gains are bigger. And it also requires high quality data, consistent metrics, modern IT. Again, needing infrastructure investments. That is it. The scenarios and everything else I've talked is in much longer way available in our homepage. You can add to the 83 comments that we received.
Wow. Ladies and gentlemen, do you have questions? There's a hand up over here. Microphone's heading your way.
Hi, my name is Kaspars. I'm from Latvia. company called IQVIA, so American company. And there are, you said in the start that if there is missing something, then please tell. So I'm not saying that there is missing a lot, but there are several things which we in Baltics are not talking about a lot. So first of all, so it's more suggestion than a question. But if you have some reflections afterwards, so welcome. So first of all, let's briefly say that the best, we all are concerned about our safety at this point, right? And here are a lot of companies which are sitting here and they are concerned about what's going to happen and how it's going to be. So the best strategy for safety is investment. So if there will be more investment in Baltics, not only in basically in Baltics, in all 3 Baltic countries, and different kind of investment, IT investment, clinical trials, more and more, all the other investments, more we will be protected, right? So, and I didn't see anything in there about such an investment. The second thing is that we have to understand that healthcare is an ecosystem. An ecosystem, as it was mentioned in the previous parts, ecosystem consists of very many players. And all those players are willing, first of all, to come forward for our patients, right? So if you are missing somewhere something, what I would urge to do, and I'm looking at the decision makers here, come to the industry and talk with us. Like I'm working with IT, and I can say now in Ukraine and in Croatia, we are doing very big projects where government is not paying for those projects, but they are using the outcomes of those projects. And actually, our manufacturers who are sitting here are paying for them just because we have benefit for the data from those projects. Like we have a rare disease registry, for example, in Ukraine, and Ukraine does not have money for that. But here, manufacturers are saying, okay, we need outcomes of that registry, so we are going to pay for that. So make a decision where you want to go, and then come to talk to industry, and industry will come to talk to you, and we can make those investments where you can put the infrastructure, for example, for AI right now. You can start to use AI right now and pay later on when you will have a budget and so on. So collaboration in between the industry and healthcare is very, 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 very important. Thank you.
Thanks so much. Do we have any other questions or comments? And if I may, then a bit shorter because we're tight on schedule. Go ahead.
Thank you. Edward Laane again, Kuressaare Hospital. Does this approach one, which I see is like a most appropriate future for Estonia, digitalized, machine-based? Would you see that there are less need for doctor, nurses, and generally medical staff?
Well, that is the hope. We know the shortages are coming. I mean, Oskar says 700 are missing. I myself think that it might be more because these trends are increasing. I mean, we need more and more health workers. We're not going to grow them. We know we have increased those university. There are more and more university students coming out, yes, but still there are shortages. So that is the hope, actually, that we do work smarter. The nurses will do work smarter. They don't need to do bureaucracy. They don't need to make notes because AI will do those. That is the hope there. But that is also the variability. We don't know how fast the AI will be implemented. We don't know the quite all of those results. But yeah, but that is the hope. Yes, we need less, not less, but maybe not as much would be the answer. Yes.
No, if you want to keep salaries, then it has to be less, as I understand.
That would be ambitious.
Thank you.
So if we have one more question, we can take it. If not, I'm happy to move forward. We have one. Go ahead.
Hi, Koit Tarro from Novo Nordisk, so not the insurance company, but my question is that somehow this equality in healthcare system is considered. First question, do you see it as a development stopper somehow that we can't consider ideas? And my question, the second question is that this private insurance somehow maybe can be considered as investment, as it can allow, let's say, more people who are working get quicker back to work, for example. I have seen it in the systems that somebody is waiting for prosthesis for half of year taking this sick leave and not able to work. So maybe this private insurance is not the issue here.
Private is not the enemy. Private sector is definitely not the enemy. I will add to that. But inequality part, I will, if I can take a minute. I mean, we looked at the data the same. It was the first study that actually looks at the data concerning private insurance. So we discovered that private insurance in Estonia works to this 400 euro tax. What's the word in where you don't have to pay tax? Exception, yes, thank you. The private insurance works through that. So the issue or the demand has been to increase it to 1,000. Okay. But we also know that only 15% of the companies are actually using the 400 euros. Only 15 right now, which tells me that the demand is maybe perhaps not as big. So, but in those 15%, it's more the people in financial sector, the IT, and when looking at the personnel, it's age 25 to 40 within good health or very good health. And in the 10th income, this also the larger income also, and more linked to the men. So we have healthy men earning a lot of money with private insurance. So when we know that only 15% actually use it right now, when we increase this to 1,000, we can suggest that those who use it now will use the bigger sum also. So, those who don't use it right now, which is most of Estonia, will not use the 1,000 either. So this is the increase in inequality.
One last question from Slido. We focus again on the redistribution, but where is the perspective on the potential increase in revenue generated through healthy, productive working years?
Well, this would be the best, I mean, but this doesn't come in 1 year or 2 years. Investments in healthy life years would be the absolutely best results, but this.
But you didn't model it.
No, we didn't model it. We know from our last studies, but yes, when we lose like 10% less years to alcohol deaths, this is like 700 millions. Huge amounts of money. But this
so increase alcohol tax by 20%, win a lot of money.
Yeah.
Who's the next Minister of Social Affairs and Minister of Finance who wants to do that?
Exactly.
It's been tried.
Exactly.
I can tell you.
Efficient, but in the future. Yes.
Yeah. Right. Thank you very much.
Thank you.
Ladies and gentlemen, let's now look at a positive, possible part of a positive solution, how data and new analytical tools can actually help us to see health investments, again, not as a cost, but as measurable economic value. Please welcome Heleri Tasane from HC Solutions with her presentation, Quantifying Health Investments as Economic Value. Go ahead.
So hello from my side, and next to the presentation, complementing Kaupo's last messages about the value of healthcare and the value-based healthcare. So the financing of healthcare is ethically and politically very sensitive topic. And in public discourses, we haven't talked much about the economic value of better life and better health. One of the reasons maybe behind this trend is that we have deep-rooted apprehension that healthcare is a societal responsibility. And it signals the valuation of human life and the health. But as Kaupo also mentioned, many analysts, including McKinsey, have also witnessed that the systems are strained financially. There are existing funding gaps, inefficiencies, and persisting inequality. And these gaps actually become more and more important since the population is aging. There is less workforce in the job market, and therefore also less taxpayers to finance these systems. What we try to do in Insight is that we try to change the narrative about healthcare financing, whether we talk about health as a financial responsibility of the societies, or we talk about it as a national investment into human capital. So what is the problem actually? The problem is half of the equation. So the current health technology assessment systems, they focus on clinical outcomes, the quality of life, the cost efficiency. But this is only the half of the picture actually, what the healthy years brings us economically. These assessments currently, they don't consider the economic impacts that if the person has good health, they return to the job market, they contribute to companies' goals by creating economic value, they earn salary, they pay taxes, they consume in society, which all actually returns as government revenues from these consumptions, taxes, and economic activity. And since we often look only at the one part of this equation, it leads to systematic under-evaluation of new interventions, technologies, and etc. In understanding the entire effect of these interventions. And as a result, there is delayed uptake of new interventions that may be more effective in long term and target the long-term economic value of healthcare interventions. So it won't get any better actually unless we start thinking about healthcare not as a financing but as an investment to human capital, and not ask ourselves how much we spend, but how much we can bring back to economy with these investments, and understand that these investments actually can drive economic growth and contribute to sustainable economic growth in the long-term perspective. And actually the irony is that since I talked about the aging population, we talk about really much, but I sometimes feel that we don't apprehend the actual problem about this declining population. Well, one thing that we all in healthcare know is the fact that it puts a lot more pressure to take care of the elderly people, also in healthcare. But the another thing is that there is less and less workforce contributing through taxes. And this makes the human capital more expensive for the economy and for the companies, because we compete for the smaller proportion of available workforce in the market. And usually, the higher the human capital level in employee, the more mobile these employees also are, putting serious constraints on keeping actually the intellectual capital of this workforce in the nations. So if we ignore actually the entire picture of what what economic value the healthcare interventions make, we actually may even steepen the problem of future healthcare funding, because we don't see the entire picture, and which leads us there that we compete internationally for the same people, for the same workforce that actually contribute to the governmental budgets, tax revenues, and also future employment. So in Insight, our mission is actually to make this invisible economic value of health more visible. And to do that, our goal is to link the current clinical outcomes that we are used to follow in understanding healthcare interventions with workability and therefore also quantifiable macroeconomic impacts. So if we bring back, for example, 10% of the people to the job market, what it does with the GDP, what it does with tax revenues, what it does with national productivity rates, and social costs, because one thing is that we lose in tax money, economic activity and productivity, but the another issue with undervaluing the economic effects of health is also it increases other costs like social costs to provide societal services for these people and etc. So there's also alternative costs. And to answer this question more clearly, we plan to introduce a new measure, which is total net benefit, which shows net value for the society of the intervention and its effects, and also the break-even time, which shows when this intervention or investment returns to positive return. And by doing so, we can evaluate health the same way as we currently do for other societal fields, for example, introducing new schools or new industries or etc. And we aim to achieve it by contributing with University of Tartu. We have potential access to Big Heart database, which consists of 770,000 individual people's data, which enables us to use machine learning-based microsimulations to simulate different interventions' impacts on patient trajectories. And we can link these outcomes with more common and scientifically proven macroeconomic simulation models to see that what those trajectories show over long time horizon and how they contribute to long-term GDP, productivity, employment, and governmental revenues. And the process is simple. So we start with combining the common clinical outcomes, which are in line with the current health technology assessment frameworks, with linking it to working ability and subsequent employment, taking into consideration different stratified samples, salary rates, economic activities, potential to return on the job market, and the healthy life horizon, and contribute therefore this to quantifiable economic value that we can fiscally and monetary track. The most important part of this project is actually a scenario simulator that enables fast, transparent decision support. And the scenario simulation enables to simulate the target populations, intervention uptake, efficiency, the cost, and explore best case scenarios, worst case scenarios, and the base level scenarios. And by that, it supports the strategic planning, especially in underperforming areas, by enabling to answer what if questions. What if we do so? What if we invest in this intervention or in that intervention? We put more money, for example, in prevention or other fields. And by that, it actually also reduces the need of additional analysis to understand the full picture of different intervention and different possible scenarios. And in prototyping, we plan to apply it first on the Estonian data and then build the system so it will be scalable for different countries' contexts as well. And the whole project is actually aligned with the new European Union Health Technology Evaluation Framework, which actually aims to harmonize clinical assessments, but also leaves the economic assessment as a national responsibility. So in that sense, we have a unique opportunity to position ourselves by combining these new regulations with the national context economic data like national salary levels, productivity, employment rates, disease burdens, and demographic trends that are happening over time in the economy. And why Estonia? Why do we start with Estonia? Very small market in that sense. But the benefit of Estonia is the fact that the smallness is also our advantage. We have thin public structures that enable cross-institutional cooperation, more efficient decision-making, and also the digital history of Estonia actually have contributed to small but data-rich population and different registries that are interoperable. And since the new European Union Health Technology Assessment Framework harmonizes these clinical outcomes, then the architecture of the project is scalable for different countries, different contexts, and the architecture of the model itself remains the same. So, to close up, what we need to conclude from all of this. First, that is we need to start considering the investments in healthcare as drivers of economic growth, because one part of this economic activity is labor. The people that work, the people that innovate, contribute, pay taxes, are economically active, and link that with better health, healthier years, and see it as a full picture. And as a result, in long term, it allows us to actually strategically better plan our budgets, plan our investments, because we have the full picture that which areas are actually the gap, which technologies or interventions, maybe even if not cost effective in short period of time, bring more back in longer time horizons, and therefore compensate actually the investment cost that we initially need to do. And also more transparently. So, thank you. I'm looking forward to your questions.
Thank you indeed. Do we have questions? Or it was all too clear? It was all too clear. Thank you. We'll move on with the panel then. Thank you so much. Indeed, ladies and gentlemen, it's time to move ahead with the last major debate of today. The last panel, titled From Efficiency to Impact, Scaling Investments That Save Lives and Strengthen the Economy. Sounds really good. Let's see what we can come up with. And I'd love to invite onto the stage our dear panelists, Mariken Ross from the Ministry of Social Affairs, Jan Ajal from Tartu University Hospital, David Illman has several posts, so in the University of Tartu, Foresight Center, HC Solutions, and Tuuli Seinberg from the Estonian Chamber of People with Disabilities. With your applause, ladies and gentlemen, it's good to kick off the panel. I see we're still connecting the last microphones, but we will be ready in a minute. Now, dear friends, as previously noted, I do appreciate your questions and comments, both from the floor and also through Slido. So let's see, who are we still missing? Do we also have Taavi joining us? Taavi is somewhere adding a microphone. So, but let's begin. Let's use the time that we have, because time clearly is limited, and Taavi will join us. Now, Mariken, we saw those 3 scenarios that were investigated. They were data-based, so there were not utopias, dystopias, they weren't fantasies, they were really welcome. They were really based on the harsh reality that we live in. Now, I'm afraid the most depressing scenario was the one that looked the most familiar to me. Please prove me wrong.
I would if I could. Because,
that's where we're heading.
Yeah,
too little,
I assume
too late,
you're referring
and
to
bankrupt.
Yeah, I assume you're referring to the too little, too late scenario, which unfortunately I don't think that anybody can deny is being the case for some years. We've known for years that the Estonian healthcare system will end up in insufficient funds, and it shouldn't be a news to anybody. But I would like to answer to your question with a little bit of more positive view, because there was a very nice question, and Kaupo actually answered also quite well, but it was the question of productivity years and the healthy lived life years. So when we combine the scenarios from the report, of course, I mean, everybody who saw it, everybody thinks that the digital version is the way to go. Yes, probably it is. But Kaupo also said that the value-based healthcare is the way to go, although it is much more complex to implement and it is much more complex to integrate into our reimbursement system at the moment.
Can we afford to actually choose one, is the question, or should we implement both?
No. My opinion is that one can't be without another, so we need to combine them together. But the value-based healthcare in itself also includes prevention, also includes the healthy life years. It's not only a healthcare, it's the paradigm of the full patient life cycle. So that would also answer to that question, how do we increase the healthily lived life years? We need to combine those scenarios.
So it's 2025 is ending pretty soon. I look at my
not
calendar.
That soon.
And 29, when the bankrupt arrives,
leaves us 3 years.
Not too far away. What are the 3 major reforms that are on your table right now to get to where we really want to get?
Strategic buying and value-based healthcare, which are in the government program as well. So these are the 2 things that I think mostly answer to your question. This means trying to find the most optimal way to implement the value-based healthcare. Yes, and it also means implementing the value-based reimbursement with the digital technological advantages.
We heard a question from a colleague from Latvia that if you want to make big investments in IT systems, ask the industry. Have you tried that?
Not in my current position, I haven't yet, but I do like to clarify that I've been in the Ministry of Social Affairs for about half a year. So
there's still time. There's still time for you to ask.
So maybe I haven't yet found all the partners. But this is not, in essence, this is not a new idea, because the collaboration between our hospitals, for example, and the data usage has been throughout the years quite, I wouldn't say active, it could be better, but there are examples. So it's certainly something that we should look into.
Jana, when you look at where we're heading, I mean, scenario 3, as I said, sounds familiar to me. What should actually be done to move forward value-based healthcare? Because, I mean, quite often when we talk about it, it seems as if hospitals and doctors are not too enthusiastic about this idea. Am I wrong?
Yes, I would say.
Okay, yes, glad to hear.
I agree with our Minister of Social Affairs that there are a lot of things we could do better, definitely, without any extra money. And really, I completely agree with you that if we discover something, then we shouldn't stop there, but we should also follow what happens after that. Just one small example, cervical cancer screening. We just quite soon will publish a paper that says that those women that are already affected, they have already pre-malignant lesions, they are lost to follow-up. They are lost. Around 50% of those women are lost.
Why is that so?
We don't know it exactly, but we discover something, but we lose these people. This is one thing. The other thing, what we are very much aware of is that if we talk about early detection of cancer, then we talk only about screening methods. But if you look to the data of cancer registry and screening registry, then in 2022, only 5.6% of malignant tumors were established through screening programs. So it means that nearly 80% and more people rely on early detection of cancer that is based on symptoms. And we know that, actually I have a very good example of one collaboration between Ministry of Social Affairs and the university and pharmaceutical companies. We assessed the pathway of lung cancer patients. And what was seen was that, referrals that point already on cancer, the proportion of these referrals increase within 3 to 4 months before the diagnosis is established. So it means that we lose people and we lose lives. So being too late in oncology means that we are really losing a lot of lives. So there are so many things we could do better, and especially we should prioritize flow, and digitalization is very good part in this. So we can be definitely better, but on the other hand, we also need some more investments, because treatments are very often curative, and those people survive and work and use everything that pushes up economy. So we need different ways to reimbursements as well.
Tuli, how could actually patients group help identify where investment would make the most difference?
Well, first of all, I'd like to add to the previous comment that we need also patient education. We need health literacy programs so that patients themselves could make better health decisions.
So they prompt on ChatGPT before they go to the doctor?
Not that. They could do that. But if they are given from starting from the kindergarten through the secondary school, through the university, the knowledge that supports the healthy lifestyle choices, then they could turn in a bit earlier. Now, patient organizations can also add to these educational programs and empower the members. But in order to do so, our patient organizations need also sustainable funding so that they could be part of this big picture.
Davi, based on your models, and it's a really open question, where are really the biggest untapped opportunities in Estonia for health and economic gain? Where do you see that, the door is open, we should just walk in and decide that this is the way we should go?
The short answer is everything we've already spoken of this morning. They're all very attractive and appealing options. We should do them all. It's very difficult to think about how to prioritize them or choose one or the other.
Well, choose three.
But if I had to try to think of a schema of thinking about how to choose them, I quite like the metric of money in and life out, or years of life out, or qualities out. But if you extend it with health out, but also some social value out, you get similar answers. So in terms of efficiency and cost effectiveness, the top things are probably going to be things that are our biggest risk factors. So some of them are quite boring and old-fashioned, such as blood pressure control, number one risk factor in Estonia for qualities and life expectancy. Still, most people who need blood pressure medicines don't know they need them, and people that take blood pressure medicines don't take them to the right level. So that's a very simple thing. Even though those drugs have been around for ages and they're quite cheap, they're just massively underused.
How do you change that?
But even if I'm thinking about, we're developing protocols where we want to take the existing ChatGPT version and pre-tune it with Estonian guidelines and patient support leaflets and advice to give such novel services available to people that have been recently diagnosed with blood pressure control issues. But fortunately, we don't have very good funding mechanisms in place. So we're doing a lot of this innovation essentially pro bono or free. So ideally, we'd love to have access to new initiatives that allow for funding for new service developments like this. We have funding available for late-stage cost-effectiveness evaluations and effectiveness studies, but service development is actually still massively underfunded. So that's an area which could potentially be opened up for great gains to be made thereafter. But if I've parked blood pressure control as a slightly boring, old-fashioned risk factor out of the way, another very big and large risk factor is obviously cholesterol, for which we have some existing old drugs that are massively underused, like statins, but also very exciting and powerful new drugs like PCSK9 inhibitors and inclisiran that could potentially be used for, again, large groups of the population. And maybe the third big risk factor, which should be on that list, is obesity and weight, for which there are obviously dietary nutrition approaches, but also pharmaceutical approaches, again, massively effective and cost-effective and underutilized. So I guess those are my big three risk factors: blood pressure, cholesterol, and obesity. And if we even did, a quarter of each and did that well, that's probably the best bang for buck that we could do with public funds that I could think of.
So what's the budget to really make the most impactful first steps in those innovative tools that we could use for prevention and early detection? Are we talking about hundreds of millions, tens of millions? What kind of models do you actually see in being successful for financing these digital tools?
If that's directed towards me, the initial, the size of the investment could range from 0 to potentially capped at something in the ballpark of maybe, after getting to 300 million, after that I run out of ideas. But if you gave me 300 million to invest tomorrow, I know quite well how to spend that money. And the initial returns on investment are tremendously efficient. So it's not a linear kind of money in and efficiency out. You get massive bang for buck initially. And after that, it gets a little bit difficult to optimize the subsequent returns on investment. But I guess for the first 50 to 100 million, I'd know exactly where to put that money and to make that really work well. After that, as you're getting towards hundreds of millions, it gets a bit harder. That's my ballpark, but maybe it's slightly beyond my usual comfort zone. There might be the people in the room that can answer better to that question.
Have you guys met before and discussed that?
No, we haven't discussed the money yet.
But the probable projects that would get the biggest influence.
No, but I do get a hint that I should look it up and set up a meeting.
It's a good moment to do that. Yeah. Right.
On that point, if I can just mention, we put a proposal into the Health Insurance Fund's innovation scheme, which is quite a sort of what we thought was a reasonable, modest proposal, costed at about, for 5 years, maybe 3 million euros. And the response was basically, it looks good on paper, it's got great bang for buck, it's great cost effectiveness, but our budget doesn't not have that capacity. If we fund this, we can't fund anything else. So we have fantastically innovative and cost effective ideas that are ready in the pipeline, but we just have the budgetary squeeze, which means that the funders are not able to fund them, which is really sad. But the ideas are there, we just need funders to fund them.
Mm-hmm. I mean, how much hope would you put on those new digital tools actually to solve the issues that are, I mean, red, blinking, that need solving?
I would say that it's not magic, so it won't solve all the problems. I am a bit hesitant to say that it will lower the need for personnel. I would say that it will lower the need of increased personnel. But I'm not sure that we can really take some nurses or doctors out of the system and replace them with something. I think that AI, at least in the next few years, is a tool rather than supplementing somebody with something. It would help us tremendously in some of the cases. For example, I would come back to Jana's example. So when we're talking about early screening for patients, early cancer screening, for example. In Estonia, what we do have, one is the digital radiology central bank. So all the radiology is in one place, and we have the blood analyze results also seen in the national system. Would there be an option for an AI to actually go through the radiological pictures that are done because of some other causes? For example, we have somebody coming in with possible pneumonia. The radiologist looks for pneumonia, but all of those pictures are then scanned by AI looking for early signs of, for example, any other type of cancer than the lung cancer, because when you come in with a pneumonia, then the radiologist looks at your lungs. So there are ways to implement AI much better than we are doing today. It all comes down also to the data usage and the data protection laws. But we could do much better. I'm not necessarily implying that it would lower the costs, but it would reduce the need of further lines of therapy or help us to get to people better in the earlier stages.
Jana, I wonder, how do doctors actually see those digital tools? I mean, I'm wearing a smartwatch, I'm wearing a smart ring when I go to sleep. A lot of data is being gathered. In theory, this could all be used to keep me healthy, above the statistical average of healthy years that I have left. That makes me actually worry quite a lot. So how do you see the digital tools? Are they as powerful as, well, some would like to think?
Probably it depends also on a person. There are very interested person that want to use this data and they are really trying to follow all these suggestions and so on. But we have also patients or people that might be too nervous about findings, and a lot of that may cause a lot of stress. So it all depends. But whatever digital tool we would use, there should be a kind of teaching how to use them, how to understand these values we get out of them, and so on.
But are doctors open to that, or are doctors more or less skeptical? As we heard from the report also, that using this AI and digital tools, we actually could afford to have less doctors, which is, I mean, something looking at the budget we probably need to consider.
What I would expect as an oncologist out of all these tools, I would like to have a tool that will help a patient to understand that based on this, that, and third symptom, this patient might have a really severe disease. I would like to have a tool that would guide this patient from suspected cancer to a cancer center and to a right diagnosis in a right time, and that this patient wouldn't wait for treatment for weeks and months, because we are really losing very much time there, and we are losing a lot of lives there. But digital tools is just one piece of the pie, actually. Mm-hmm. We need also treatments to treat these patients, and I would say that in oncology we have had such a tremendous changes within the last 10, 15 years. And for example, just one example, very aggressive skin cancer, melanoma. We had median survival time of these patients as short as 6 months, but today this is 6 years. And all these innovative drugs and solutions are tested in late stage diseases, but all these drugs come to earlier stages where we can cure people. And that's why we need also, on one hand, digital solutions to be better in things we do, but on the other hand, we need additional investments to have all these possibilities for our patients to be cured at earlier stages, because they are people that work and push economy.
Totally.
Yeah, I wanted to add that for people living with disabilities, digital tools could be the one and only access point to reach the actual medical help, to reach the healthcare services. Younger generations with disabilities living outside of cities, they do not have sometimes social transportation to go to the family doctor. Right now, these simple digital tools, which are not directly medical services, but access points, help them immensely already. And in regards to this age gap in implementing and using digital technology, I think that right now the generations already grew up with digital technology. They use these, they eat them for breakfast. It's the normal environment already. So we can't let us hinder by the concept that aging populations don't use them. However, we must bear in mind that all the technology as well has to be accessible by all the population groups. So universal design in everything and access for everybody.
So I'm going to take a few questions from Slido. To improve adherence, should we use data much more bluntly? For example, showing people how non-adherence affects their life expectancy instead of waiting for the consequences to show up as, well, cardiovascular disease. Go ahead.
That's a fantastic suggestion. And I personally think, yes. And the more personal that communication can be, rather than saying, please take medicines, rather than that saying, if you don't take this specific medicine for this specific disease, your prognosis is going to be between these two lines. I mean, that's the sort of way I, as a patient, would like to think and would like to see information.
So scare people to death, basically, with the data. And, well, that's clearly how a person asked. I tried to rephrase it as a more polite way. But so let's use data to scare people to death. Other than letting them die later to the...
But even though I quite enjoy this humorous framing, I mean, if I go to a shop and buy a jacket and I'm not sure, what's hiding inside the jacket, how many buttons it has, how many pockets it has, I want to know exactly what I'm going to get for my money and when I imagine what I'm going to have when I put it on and when I have in the real world after I buy this thing. I need a very clear understanding of what's going to happen with me after I take this product and use this in the future. And the same goes for medicines. I'm not sure if scaring to death is the right framing personally, because even though I get the joke,
let's scare to near death.
I think it's
not to death.
No,
then it's something to fix.
I get the joke, but personally, I think what it's more about is imagining two futures, two scenarios. I have a very rightful choice to make, and if I don't take this pill, which gives me great pleasure because then I feel more healthy. I don't need to see the burden of taking the pill every morning. If I go through the burden of taking a daily pill, which is quite an important investment, plus potentially monetary costs, I need to imagine very clearly what exact benefits I'm going to get. And that's not scaring to death. That's explaining what the benefits are in a personally understandable and an emotionally salient manner, which I think, to be honest, especially when people don't yet have symptoms, when they have very early stage diseases, that's very difficult to imagine. So the more we can use imaginations and visualizations to imagine that scenario, the better. And that's a very important and valuable goal for all of us to get behind, personally.
I can just add that we are creating right now so-called fast track from suspected cancer to first treatment, first of all for lung cancer, but we would like to try another tumors as well. And we have in our working group representative of patients. And she all the time says that we are not afraid to have suspected cancer, but we are afraid of being late. And this is the message she all the time says.
Go ahead.
I would just add, and maybe, well, don't everybody think of Robocop or something now, but there's a type of studies out there already for several years named different names, but basically it's digital twins. So, you know, they make a digital copy out of you, and it's not only your habits, but it also refrains to the clinical trials. So they can make a medical digital copy out of you, and then you model how this type of drug would work on your tissues or would work on your cancer or would work on whatever thing we are trying to model. So would we like to live in a future where we would have our digital twin in our mobile phone? And I can see that, yes, if I'm eating too much of a cake today and I continue to do that for 10 years, then my digital twin in that scenario would have obesity rate of something, the heart attack rate of something else, and that would, in that case, affect my outcomes. So from a medical point of view, I would say that, yes, that's nice. From the personal choices point of view, I'm not that sure I would like to have that. So that's maybe a bit of a thought about scaring people.
Well, on one hand, you have possibility to have health anxiety. On the other hand, you have the option to make informed choice, to make informed decision. So that's the finding balance, actually, between these two options.
And if I may lead on to that, which is a fantastic intro, personally, if we're considering future risks that are very difficult to control or mitigate, for example, some more, perhaps more genetic risks for which we can't really do that much about, I don't know how much value there is in simply telling people about the risk if there's no discrete plan of action of what to do to lower the risk.
Exactly.
Whereas if we have very clear and available and accessible, for example, drugs or other interventions that have been standardized, measured, they're effective, they're cost effective, then I would argue that it's very important we give people that option and that choice, because some people may say yes, others will say no. If we restrict the choice and don't give that option to them, that's very bad practice. And likewise, going back to the options of diets and chocolates, sometimes we have too much choice, and it's quite legitimate in the supermarket to maybe restrict the choice a little bit to make it easier to choose the right healthy option. But often when it comes to preventative pharmaceutical drugs that help people stay away from disease in the future, I think we usually don't make that offer clearly enough, and we need to make that often more often.
Right. I would love to hand the floor to the dear audience. So if we can perhaps get the microphone first in the front row here, and then we have active participants. Go ahead.
Yeah,
I have one comment and one question. The first comment is about changing. When I start my topic, was about biases and how biases affect that we have all know that we have those biases as well. Then people have it in different ways and are reflecting different forms. That how we can give those persons the information in a way that are actually going to change their way of seeing this. But for example, screening is a very good example. You never believe that you are going to develop cancer one day, even the probabilities that every one of us in one moment are very high of having cancer. Then how we can inform the person that actually are going to change those bias individually. That's one idea. And the other is what I'm having missing here a little is the private part, the private companies' role in all this conversation. And if we think about that, most of us spend a lot of hours of the day working. Then what a company can do to help that all of this implementation have an actual effect. For example, if a woman have 2 children, need to go back back home, work a lot, work in the office, they will never have time to have a screening. That will be the last thing in the possibility option. But if a company gives you 1 day of holidays to do that screening, then she will do it. Then how we can change also the incentive for those companies to invest in a way that giving them a reason to invest. That's why we are going to get back if you give for example, in this example, a woman a day extra. Yeah.
Go ahead.
Yeah, I might start because this is my favorite topic, interventions and the communication, healthcare communication. Usually, at least in Estonia, it was done via campaigns. We have big posters on the main junctions, and there are either carrots or kind of slogans, come and do your preventive injection or something like that. We need more personal interventions, more personal levels, so that people know the stories, they know the impacts of what will happen if they don't make this decision right now. We come back to this fear moment here, but it's true actually, it works this way. And more personal the intervention is, on more personal level, the better it is. You have to understand what consequences this decision has, actually. And on the employers level in Estonia, we have kind of health-friendly employer label or something. And employers can have this label. They have to complete and do certain steps to get it. So this is something which could be included in the program, actually, that you inform your people of the opportunities, either to get a vaccine in case of vaccine avoided or vaccine prevented diseases, or to do something else for your personal health. So this is one of the possibilities I see.
I would say Estonia is a very small country, but very diverse. I mean, and people that live in different regions in Estonia need different measures. Mm-hmm. And definitely it would be enough maybe to have some advertisements in pharmacies in northern eastern part of Estonia, but you need to call to patients that are living in south of Estonia and so on. That's why there is no definitely one measure that works for all. There should be a kind of tailored individual measure. And I'm quite lucky you said that this is a good option to have a free day to have screening. That's a very nice option and very good idea.
And we actually do have health days available in majority of enterprises.
Yes, and we also have example in the legislation. Everybody knows that you can go and give blood. So you can be a donor, blood donor, out of your working hours.
So let's take one more question. Did I see a hand? I see a hand up here. Go ahead.
Yeah, thank you. Evita from Roche. I want, like we hear today and in different conferences that digitalization will save the healthcare. And yes, potential is very huge. But I have a question. Do you have a clear pathway in Estonia how these digital health solutions actually reach the patients, specialists, health administrations? Because there are so many solutions developed already. You don't need to come up with new ones for every challenge. And I talk about this pathway. Is it clear?
If I have to answer shortly, then no. Because I don't think that we have anybody who's aware of all the options on the market or all the possible new investigations or something. I don't think that we have any of the centralized information. If you are asking rather, do we have a pathway how to continue with our data digitalization? Do we have a pathway to continue with national IT system in the medicine, then those we do. But this very big picture that you are referring to, I don't think that we have that kind of view.
Right. More questions? I don't see. Oh, I see one. Okay, go ahead.
Yeah, thank you. I have two more questions to the panelists. So the first question, if we go to digitalization, so the essential question is, let's say in 2035, does technology controls human decisions? I mean, who has a upper hand? Is it a human or is it a digital ID? And the second question goes to the value-based, let's say, payment. And I think in this whole value-based means also economy, some kind of monetary aspect. So in this case, if we treat, let's say, patient with cancer who is 50 years old or patient who is 85 years old, does it make any difference? Thank you.
Difficult questions. I like those. Who wants to take them?
You cannot take away responsibility of a doctor. You cannot take it away. In every step you have in medicine, there should be a person that confirms a kind of finding or a kind of solution. About age, when I started in oncology in early 2000s, then I remember that we had a lot of discussions in our big auditorium in the morning where Professor Karl told that this patient is 70 years old, it has no sense to treat, elderly. But 70 years old person is young nowadays. So what we as a doctor usually say that everybody should be treated. Even in this 95 years old patient, whether if the condition is good enough and if we have a treatment that causes very, very few side effects. So age shouldn't be a restriction nowadays. General conditions and treatments available, I would say. And all the digital solutions should be around these thoughts. I think so.
Go ahead.
And just to build on that, which I agree with, I think that maybe just to illustrate three examples, let's imagine that 3 patients have cancer and there's options to give them a very expensive drug which may cure them of that cancer. In all 3 examples, one person is 50, one person is 85, and the third person is also 50. It's interesting to compare 2 people aged 50 and what their baseline function is and what their prognosis is once they've been cured. If one person is already quite healthy and lucky, if they've been cured, they may well live for, let's say, 30 years or so. So that drug and that intervention is going to deliver 30 years of lives, 30 life years, if you will. Whereas giving it to a person who's aged 85 depends on what their life expectancy might be. Maybe you'll extend life by 1, 2, maybe 10 years if you're lucky. So the current health technology assessment process already gives preference for interventions that are more efficient and effective at early ages. And that's a normal thing we've accepted. However, another person aged 50 who may, let's say, already have been injecting intravenous drug uses, they may be amputated, they may already be disabled and have a very low life expectancy to go with, that intervention for that person may not be very effective or cost effective. So it's more about the person who's being given that offer rather than the age, but age is often a very powerful predictor of benefits amongst other considerations as well. That's the current model we've accepted for decades, and that's the way we run the show. I think what's been discussed today is the idea of adding in not just the prognosis of expected life years and QALYs gain, but also if health is delivered, what kind of economic benefit will that person go on to produce, both in the paid economy, but also in the unpaid economy as such. And that's a very exciting new concept, which I think we haven't really contemplated to date, but if we bring that in, it will make our decision-making more complex, but potentially also better aligned with the values of various stakeholders.
Yeah, I wanted to add on the disability, because this is something we haven't discussed much today. In Estonia currently, there are about 100,000 people living with disabilities. And actually, these people are invisible resource we could use on the labor market with enough support, with rehabilitation, and granting access to workplaces and granting access to education. So disability is not always a cost, as today I really like this reframing this healthcare not cost as investment, but also people with these disabilities are not necessarily a cost, but underused resource. So, yeah.
Dear friends, because time is running out, I would like to come back to, I think, the main question and a call for action, if I may. So we know that big reforms are hard politically, and they're quite slow. But as time is running out, literally, what is the one politically doable action in prevention, digital health, or in the workforce that could actually produce a measurable impact already within 12 months that we should really prioritize and put our focus to? What are you currently working on that we should really not hesitate to go forward with fast?
Now, sorry, but in my mind, the 12 months is a wrong time frame, because that would be the low apples. And I'm not sure that going for the bigger steps, it's actually useful to put additional resources for the apples that you're not going to use later on, if you get my point. So we should at first have the big picture, and then we can go to the next steps within the 12 months rather than vice versa, because the vice versa is what we've been doing. What we are doing right now that will make maybe something in the next 12 months, one of the things is the integration of the social and healthcare levels. That's ongoing project and ongoing reform, and that we will see something probably in the 12 months. Also, there's constant ongoing work with health insurance fund, but I'm not giving out any promises for the next 12 months on that topic.
I can say about my specialty, that thing that really may change a lot is HPV vaccination, definitely, because not only cervical cancer is related to this virus, but a number of other tumors as well. Anal cancer, rectal cancer, head and neck tumors, and we have also data showing that HPV is present also in lung cancer, in stomach cancer. So vaccination is definitely very important and very effective way to go forward. And standardization of patient pathways through digitalization as well. This is the second step we should do to be really effective.
So that these initiatives could succeed, I still emphasize the need for health literacy programs for patients, not only patients, because we all are patients actually, in one time or another during our life course, but for all the people, starting from the kindergarten and from on there.
Davi, you have the famous last words.
Likewise, I'd love to have a 10-year horizon so I could talk about cholesterol, blood pressure, and obesity. But if I've got a single 12-month timeline, which is really, really difficult, I'd probably say look at very, very common diseases, especially ones that are hitting people before they come to the age of retirement, such as heart attacks and strokes. After their first event, they're shocked, they get a package of drugs to take home with them. We know most of the people don't take most of the drugs most of the time. There's an educational gap, like you say. Why don't we develop and offer them a new large language model, such as ChatGPT-based service, which allows them to have endless conversations that are Estonian guideline-based to bring up their levels of understanding of their disease and the drugs they've been offered to take adherence levels to the skyrocket limits. That would be my suggestion of where to intervene.
Thank you so much, dear panelists. This is the time we had for the discussion, and we've exceeded it with, well, a few minutes, let's say, if not say 10. An applause, ladies and gentlemen. Thank you so much. So, dear friends, the sad news is, as we saw from the scenarios, that we're actually losing money fast, and if nothing really changes, our healthcare insurance fund will be bankrupt, if no later than 2029. And I don't really see huge excitement from the population to raise new taxes. So what options do we really have? Efficiency clearly is one of them. So as we also heard, wages and prices have really doubled in the healthcare sector in the past decade. And well, clearly that is the cost of keeping doctors and nurses from moving, well, to Finland to really keep them in Estonia. So if we don't want to meet our doctors in Finland, and I certainly don't, we probably don't have an option to cut the salaries. So how do we become smarter and not cheaper? If we invest wisely, with the right targets, with the right metrics, every euro that we put into healthcare, as we heard, can actually bring us back 5 euros into the economy. And that's not just optimism, that's real evidence. Now, value-based healthcare has been debated in Estonia, as far as I remember, about for the last decade. Correct me if I'm wrong. It's not exactly a new thing. Perhaps it's time to take concrete steps to actually get going. Certainly, it's not a comfortable thing. It's a big reform. But given our financial outlook, postponing uncomfortable changes isn't really an option anymore, right? So more focus on prevention, more innovation, and more on real efficiency. That's how there's hope that we can really keep the system alive and actually bring in new money, both from the private sector, but also invest in healthcare that would bring money back to the economy. I guess that's how we can move forward stronger and avoid being bankrupt. Ladies and gentlemen, thank you so much. Would you like to add something?
Yes, but I will do it here as I don't have a microphone. So what can I say? It seems to me that at least in this room, we all tend to agree that healthcare is not a cost, that healthcare is an investment. So I would like to thank you all for coming, for thinking along, speaking up together, because only together we can find a way forward, and not just a way forward, but the best way forward. I would also like to thank my fellow task force members, AstraZeneca, Novartis, Roche, MSD, Medtronic. And I would also like to thank two people who are sometimes working behind the scenes, but who are actually behind the success of AmCham in Estonia, and who are also very critical to our annual healthcare forum success. So Daria and Tina, if I may invite you here. Thank you.
Working lunch?
Yes.
Ladies and gentlemen, we'll now move the conversation over to our networking lunch. All of those questions that were unasked by the moderator will be asked and answered throughout the lunch. Thank you again for joining us. I hope it was as inspiring for you as it was for me. See you again. Thank you.